Good evening,
Namaskar and
everyone.
good evening, everyone. I welcome you all for today's webinar on Lung Cancer Congress and Rare Thoracic Malignancies. For this, I would like to invite Dr. Nandini Menon, who is Assistant Professor Medical Oncology, Tata Memorial Hospital, Mumbai, to set the ball rolling and to take the proceeding further. Over to you, ma'am.
Good evening. Thank you, ma'am. Good evening, everyone, and welcome to day one of this education series on lung cancer and rare thoracic tumors. I welcome you all. And at the outset, I would request Dr. Kumar Prabhash, medical oncologist and head of department at Tata Memorial Center, to give opening comments for this session. Sir.
Good evening, everyone, and I welcome you all on behalf of the organizing committee for this meeting. And I appreciate the work put in by all the members to make a good program. Especially what I like about this program, the topics are one of them which we see in the clinic, but most of the time they are not talked about or gets missed in the most of the meeting. So my best wishes for this meeting, and thank you so much for inviting me. Back to Dr. Nandini and the organizing team.
Thank you, sir. With this, we move on to our first session. I would like to call upon Dr. Ajay Kumar Singh, my colleague at Tata Memorial Center, who will be the session coordinator for the next session. Over to you, Dr. Ajay.
Good evening to everyone. This first session will be the pharma sponsor session, and the first talk for this session is the important factors to be considered in treatment of early stage lung cancer, and it will be delivered by Dr. T. Raja, who is a senior medical oncologist and director medical oncology of Apollo Hospital, Chennai. I'd like to invite Dr. T. Raja to come and deliver this talk. Good evening, sir.
Thank you, Dr. Ajay. Thanks for your kind invitation. And just allow me to share my screen. Yes.
Yes, sure, sir.
Yeah. I think my slides are visible, audible.
Yes, sir.
Yes, sir.
Visible and audible.
So thank you so much. And I sincerely thank the organizing team for inviting me to be here. And it's a wonderful opportunity. And also thank them for giving me this interesting topic, critical factors to be considered in the treatment of early stage lung cancer. I'll begin with a couple of slides from Dr. Goldstrauss' paper in Thoracic Oncology in 2016, where he shows that 5-year overall survival outcome decreases with increasing stage in resectable non-small cell lung cancer. As you see here, a significant decline is seen as each stage progresses. And this is true. He shows that this is true for clinical stage. And also he demonstrates the survival curve for the pathologic stage to be consistently detrimental as the stage goes on. This is because there is an increased recurrence rate as the stage goes on. The recurrence rate is high in early lung cancer despite surgery. And if you look at the rate of relapse, the recurrence is 62% at stage 2 and about 76% in stage 3. So recurrence is the norm, and therefore these patients do poorly. So what are the important factors that we need to consider when we want to treat these patients with early lung cancer? We need to be aware of this recurrence rate. And then we also need to be aware of something special in non-small cell lung cancer, CNS recurrence. And then we decide, okay, what else we can do either in the neoadjuvant or in the adjuvant setting. And then with those intervention, what is the DFS and OS that can be achieved? And what is the safety of such intervention and quality of life? It needs to be considered. The ANITA study way back in 2006 showed that adjuvant chemotherapy in stage 1B to 3A would give at best a disease-free survival advantage of around 5% and overall survival advantage of around 5% after 5 years. This was confirmed by the LACE meta-analysis, wherein all major 5 adjuvant studies were put together, and you would still see the 5-year overall survival benefit at the end of 5 years is only 5%. And if you look at the recent publication by Chris, putting all these things, all these studies together and the latest meta-analysis together, where there is a retrospective analysis of the absolute benefit of adding chemotherapy, and you see that the absolute benefit of adding chemotherapy lies here in purple, and in stage 2, it is anywhere between 10 to 15%, and in stage 3, it's anywhere between 13 to 20%. So that's where the real benefit lies when you look at a retrospective analysis. So then we look at what else can be done. What is the role of tyrosine kinase inhibitors in improving this situation? That's what we want to look at. And so far, there have been a number of trials with erlotinib and gefitinib, and what they have shown, the EGFR TKIs in particular in adjuvant setting have shown a DFS benefit, and we know that there is no overall survival benefit. And in 2018, the osimertinib data, ADAURA, was also presented, which showed a significant improvement in the DFS in the adjuvant setting, and both in the overall population where stage 1B to 3A, and also in the primary population of stage 2 and 3A. If you look at the consistent, if you look at the DFS advantage, there is a DFS advantage, consistent 2-year DFS advantage. But if you look at them stage-wise, at stage 1B, you have the hazard ratio of 0.39. At stage 2, you have an hazard ratio of 0.17. And stage 3A, you have a very, very impressive hazard ratio of 0.12. And it was shown that with osimertinib, there is a decrease in recurrence. And whereas with the placebo or the conventional arm, you will have a recurrence rate of around 46%. And osimertinib showed a recurrence rate of 11%. And also that there was a reduction in the systemic recurrence as compared to the control arm with osimertinib. And specifically with regard to CNS recurrence, in the adjuvant CTGONG study, it was shown that among all recurrences, 27% of them had recurrences either in the brain or along with brain. And in the RADIANT study, 37% of such recurrences involved the CNS. We know that the osimertinib has a better CNS penetration with a better, blood-brain barrier penetration. So you would expect that osimertinib probably will do well, which was already shown in the metastatic setting, wherein the CNS progression is shown to be 1/3 of the control arm. So that benefit was already established. So in ADAURA trial, you would see that the CNS recurrence was also very low, to the tune of 1% as compared to 10% in the control arm. And the better CNS DFS was also published at that point, and we see that the DFS advantage is 0.16, 0.18 hazard ratio, and the DFS is not yet reached. This is the CNS benefit, CNS DFS benefit with ADAURA with osimertinib. We already know the safety profile of the first and second generation TKI. They have an adverse event, grade 3 adverse event to the tune of 15 to 40%, both the first and second generation TKIs. Fortunately, the osimertinib shows an adverse event profile of around 10% in the adjuvant setting, a grade 3 adverse event 10%. So what is the role of immune checkpoint inhibitors in the early stage setting? We see that a number of trials are on wherein there is an adjuvant immune checkpoint inhibitor monotherapy with pembrolizumab, with nivolumab, with durvalumab, and atezolizumab. And the IMpower010 atezolizumab, the data was presented last year, and it shows that there is a DFS benefit with adjuvant atezolizumab in all patients stage 2 to 3A, that's the primary endpoint, where there is a DFS around 42 months as compared to 35 months with the basic supportive care. And in particular, in these patients, whenever the PD-L1 was more than 1%, you see that the DFS is not yet reached. But the DFS benefit, even though is seen across the subgroup, it specifically is well pronounced in stage 2 to 3A, wherein the PD-L1 is more than 1%. And in the intent to treat population, if you look at the DFS curve, wherein the intent to treat population including 1B to 3A, the DFS curves are more closer than this PD-L1 more than 1% population. But if you look at the subset analysis, you will see that there is no DFS advantage, particularly if these patients express EGFR or ALK. suggesting that probably in patients with driver mutations, this adjuvant atezolizumab may not be effective, but they are effective as the PD-L1 status increases, and you see the best outcome with PD-L1 more than 50%, wherein hazard ratio of 0.44 is reached with the adjuvant atezolizumab. And what about neoadjuvant immune checkpoint inhibitor? We know the data of Checkmate 816 nivolumab that is published last year. What is the takeaway from there for resectable patients stage 1B to 3A, in which nivolumab is added to the conventional chemotherapy before surgery? The primary endpoint is PCR, and when nivolumab is added, you have a PCR of 24% as compared to 2.2% with chemotherapy. But if you look at the subgroup analysis, you will see that this advantage of PCR is across various subgroups. Whatever be the PD-L1, you see this advantage. Whatever be the stage, you see this advantage. And whatever be the pathology, squamous or non-squamous, you see the advantage. And also versus the TMB. But you don't see the subgroup analysis for the driver mutations here. So therefore, it is becoming increasingly clear both in the adjuvant and the neoadjuvant setting, there is no data to support that these interventions, either in the neoadjuvant or adjuvant, will be effective whenever these patients are driven by the driver mutations. So we know that the biomarkers are very important in our day-to-day decisions, in diagnosis and in prognosis, and also in predicting the treatment efficacy. Therefore, it becomes very effective and very important to include these biomarkers in the same critical factors that we need to consider for treatment of early lung cancer. So you need to put these biomarkers and targets in place before you start considering the neoadjuvant or adjuvant option. So that's the best way to go probably. And so there are efforts onto that line. You see that, this is the NeoADURA trial, wherein there is a phase 3 trial of osimertinib in the neoadjuvant setting in patients who have the exon 19 and L858R mutations, and compared with placebo, osimertinib, and osimertinib plus chemotherapy followed by surgery. And ADAURA-2, wherein specifically the stage 1A adjuvant trial, phase 3 trial with osimertinib, specifically including patients who have lymphovascular invasion and stratified for high risk and low risk. And we'll have to wait for the results of these NeoADURA and ADAURA-2. And the ADAURA-2 in particular is very specific for non-squamous histology. Another interesting group of work is the LCMC for evaluation of actionable drivers in the early stage lung cancers, and simply called as a LEADER neoadjuvant trial, wherein you will identify these driver mutations, and in resectable patients you will put them on individualized neoadjuvant therapy, be it targeted therapy, checkpoint inhibitors or checkpoint inhibitors plus chemotherapy. This is the flowchart for the LEADER neoadjuvant trial, wherein different mutations, you will have different interventions, and we'll see what happens to these patients. And this is one of the example. This is the neoadjuvant alectinib in early stage lung cancer, wherein the tumor is downsized, and then you put the patient on VAT surgery, and at surgery you see there is a 15% residual disease. Again, other efforts that are happening here is that can we predict the occurrence of pathological or complete response with preoperative or perioperative immune checkpoint inhibitors? ctDNA measurements may be predictive, and this is the trial looking at ctDNA measurements in a prospective randomized phase 2 trial with the neoadjuvant pembrolizumab in particular. So these are all the efforts that are happening. Coming back to the critical factors in decision making in early lung cancer management, we need to look at we mentioned that we need to look at the recurrence rate, safety, and sanctuary sites. So far, all these goals have been met, and the cut has been made by osimertinib, and that has reached the pole position in the adjuvant setting so far. Everyone else and other agents are on the anvil, and they are making the effort. But I think only time will tell whether they really meet all these criteria. And therefore, to summarize the topic that is given, the critical factors to be considered in the treatment of early stage lung cancer earlier was very black and white. But all I can say is that with all these efforts, it's increasingly becoming more colorful. colorful time to come. Thank you so much for this opportunity.
Thank you so much, sir, for this interesting and to be finished on very accurate time. So we'll call out our next speaker, Dr. Nidhi Tandon, who is a consultant medical oncologist from Narayan Health City, Majumdar Saw Cancer Center, Bangalore. She will be talking on the turning tides for the stage 3 NSCLC towards the curative intent. Ma'am, now you can start your screen sharing.
Good evening, everyone. I would be talking about stage 3 NSCLC with more focus on adjuvant immunotherapy after chemoradiation. This is Globocon 2020 data, and it shows while the incidence of lung cancer was 88,000, the deaths because of lung cancers were 80,500, which shows how aggressive is the disease. It is not only the second most common cancer in males after head and neck cancer, but it is also the 5th most common cancer in females after breast and gynecological cancers. What is more unfortunate is that nearly half of the patient, 45% to be exact, present in metastatic condition. Even the rest 55% patients have local regionally advanced disease in most of the cases, and these patient population form about 35% of the newly diagnosed cases. The approach to the management of stage 3 NSCLC is usually decided by a multidisciplinary tumor board, which includes a surgical, radiation, and medical oncologist, along with a pulmonologist, pathologist, and radiologist. And we basically decide the extent of the disease and the fitness of the patient before taking a decision with the help of a PFT test, 2D echo analysis, bronchoscopic evaluation, and a decision about pathological mediastinal lymph node evaluation, apart from the usual staging with PET scan and MRI scan. The standard of care for treatment of unresectable stage 3 NSCLC is chemoradiation. We all know and have enough data to say that concurrent is better than sequential, but if we feel that the patient is elderly and have comorbidities and would not be able to tolerate concurrent, sequential will also be a fine choice. These are the ESMO guidelines, and they basically show us a flow chart of the guidelines of treatment for stage 3 NSCLC. It largely depends on whether it is stage 3 because of T3, T4 disease versus because of N2, N3 disease. If the disease is N0, N1, the patient will most likely go in for surgery, which will usually be followed by adjuvant chemotherapy with or without radiotherapy. And most of the N3 disease are unresectable and therefore are usually go ahead with chemoradiation. N2 disease is the disease which largely requires a multidisciplinary approach where we find out whether it is a potentially resectable N2 where neoadjuvant therapy has some role versus unresectable N2 where again definitive chemoradiation is important. But even with this stage, the treatment of intent is curative. The regimens of chemotherapy which have been utilized with radiation in concurrent setting are cisplatin with etoposide or vinblastine or paclitaxel in this in most of the patient, and pemetrexed and cisplatin in the non-squamous patient. Cisplatin etoposide or cisplatin, vinblastine, though are good regimens, but are usually tough to tolerate because a lot of these patients are elderly and a lot of them have comorbidities because of their history of smoking as well. And therefore, the usual regimen which we all follow practically is weekly paclitaxel and carboplatin. The sequential regimens have been studied with vinblastine, cisplatin, and paclitaxel, carboplatin. But among all the regimens, we see a very dismal median overall survival, with the median OS ranging between 25 to 26 months in concurrent setting and 13 to 14 months in the sequential setting. Sorry. Because of this dismal OS, the further studies included any consolidation therapy after chemoradiation, and whether we used chemotherapy in the form of docetaxel or pemetrexed cisplatin, or targeted therapy in form of gefitinib, cetuximab, or increasing the dose of radiation. There was no improvement in the progression-free survival or the overall survival, and hence they have not been included in the guidelines. So though traditionally the intent of treatment is curative, but the 5-year OS is only 15 to 25%, which is lesser than certain more curable metastatic patients. So here comes the role of immuno-oncology. And why was it studied is because chemoradiation induces the tumor antigen release, which upregulates the PD-L1. PD-L1 overexpression leads to immune cell evasion and T-cell inhibition. Durvalumab blocks PD-L1 and restores the T-cell function, which reverses the immune suppression and leads to a systemic anti-tumor response. So this was the hypothesis which led to the design of the PACIFIC study, which was a phase 3 randomized double-blind placebo-controlled multi-center study that included patients with stage 3 locally advanced unresectable NSCLC who have not progressed following platinum-based chemoradiation, are 18 years or older, have an ECOG performance state or a WHO performance status of 0 to 1, and an estimated life expectancy of more than 3 months. They were randomized between 1 to 42 days after completion of chemoradiation in 2:1 fashion in durvalumab arm, where they received a durvalumab at a dose of 10 mg per kg every 2 weeks for 12 months, and the placebo arm. They were stratified by age, sex, and smoking history. The primary endpoints included OS and PFS, and the secondary endpoints included ORR, DOR, and the safety profile. As you can see, the baseline characteristics as regards to age, sex, race, disease stage, and performance status were well balanced. What is important to note that about 25% patients in each arm had an unknown EGFR mutation status. It was positive in 6% of the patient, which was again balanced between the two arms. The PD-L1 expression was unknown in about 37% of patients in either arms. PD-L1 less than 25 was seen in around 40% of the patient, and more than 25% was seen in 24% patients in durvalumab arm, whereas 18% patient in the placebo arm. And these are the updated 5-year overall survival curves, which clearly show that at 5 years after the randomization, the patients in durvalumab arm had a 42.9% OS as compared to 33.4% in the placebo arm. The median OS increased from about 29 months to 47.5 months in the durvalumab arm. The progression-free survival followed a similar pattern, and at 5 years, 33.1% of the patient in durvalumab arm were alive and disease-free as compared to 19% in placebo arm, and the use of durvalumab increased the PFS by almost 11 months. What is also important to note that the benefit of durvalumab did not change with time, and the hazard ratio remained the same over the years. The benefit of durvalumab was similar in all pre-specified subgroups, and the same remained true for the PFS as well. Not only durvalumab led to a decreased rate of progression, 45% in durvalumab arm as compared to 65% in placebo, but also the progression in durvalumab arm was largely intrathoracic. Durvalumab also increased the time to this intrathoracic progression when compared to placebo. This is about the subsequent therapy after discontinuation of durvalumab, and it was found that though only 41% of the patient in durvalumab arm received a subsequent therapy as compared to 54% of the patient in placebo arm, then also the overall survival of the patients in durvalumab arm was higher. Also, immunotherapy was received by about 14% of the patient in the placebo arm as compared to 4% in the durvalumab arm. So even after the patients receiving immunotherapy after progression on durvalumab, progression, then also the benefit in overall survival with durvalumab maintenance was achieved. All cause, the grade 3 and 4 adverse events were seen in about 30% of patients in durvalumab arm as compared to 26% in placebo. This led to a discontinuation in about 15% of the patient in durvalumab arm as compared to 10% in placebo. The most significant was pneumonitis, especially radiation pneumonitis, which was seen in about 34% of the patient in durvalumab arm as compared to 24% in the placebo arm. And we all know that the clinical trial setting is different from the real world scenario, and we do have data for the real world scenario as well, in which about 1,400 patients with unresectable stage 3 NSCLC, regardless of their tumor PD-L1 expression, were followed up for 5 years after receiving durvalumab following definitive platinum-based chemoradiation. Majority of these patients were less than 75. The 43% of the patient had stage 3A NSCLC, and 51% of the patient had stage 3B and C NSCLC. 76% of these patients received concurrent chemotherapy, and PD-L1 more than 1% was found in 73% of these patients. This data also showed that the median PFS of with durvalumab was increased from 17 months to 21.7 months. The adverse events which led to a discontinuation was seen in about 17% of the patients with durvalumab arm, and the median time from durvalumab to the start to discontinuation was about 2.8 months. What was important to note was no new adverse events were seen. The median time to onset of pneumonitis or from durvalumab initiation was about 2.5 months, and corticosteroid administration was required in about 71% patient. So, summarizing, durvalumab is one drug which increases the median OS from about 29.1 months to 47.5 months, while increasing the PFS from 5.6 months to 16.8 months. Though 30% of the patients had grade 3-4 ADR, only 15% of the patient discontinued, and only 6.3% of these patients were discontinued due to pneumonitis. Hence, it remains it is one of the drugs which has really shown statistically significant and clinically meaningful improvement in overall survival in stage 3 NSCLC. Thank you.
Thank you, ma'am, for this comprehensive talk. We'll move on to our next talk of this session. The next topic is real-world evidence of osimertinib as a standard of care in the management of EGFR positive metastatic non-small cell lung cancer. And it will be given by Dr. Bharat Vaswani, sir, who is a senior consultant and medical oncologist in the Yasoda Hospital, Hyderabad. Over to you, sir.
Good evening. Am I audible and are my slides visible?
Yes, sir.
Just give me 1 minute. Yeah. So the topic that I am discussing in the next 14 to 15 minutes is how did osimertinib fare in real life studies? And first of all, let me thank the organizer, Dr. Vijay, Dr. Akshay for the kind invitation, and Dr. and Esther for giving me a chance to speak on this important topic. Now, when we talk about osimertinib, the first trial that comes, or the main trial that comes into our mind, is a FLAURA study, the pivotal first-line study which compared osimertinib with first-generation TKI. And what is study conclusively shows that there was a statistical significant improvement in median progression-free survival with a reduction in the risk of progression by 54%. But the most important takeaway from this study was a statistically significant improvement in overall survival with a 20% reduction in the risk of death. Now came, and that made osimertinib the treatment of choice. Now, this was a study which was finally published, the final presentation by Dr. Ramalingan and his team in ESMO 2019. Now, this study again compared osimertinib that I have already told. There are few things which I will like you to remember, that only stable CNS metastasis was included. Now, why it is important is because a trial consists of patients who are ideal. So no comorbidities, no CNS, symptomatic CNS mets. And there comes the role of what we call as real life studies, where all comers are taken irrespective of comorbidity. And it is important to know that how these patients fare. So for me, this is as important as a pivotal study, because what we do in real life is as important as in the clinical trial, which is the advanced setting. As I have already told, all the subsets had an improvement in progression-free survival, including L858R, and more importantly, 20% reduction in the risk of death with an absolute gain of around 6.8 months when we compare with the first generation TKI. And this trial made osimertinib, or is reinforced our belief that this is the most potent drug. Based on that, it is included now in the NCCN guidelines. There comes my topic of discussion. Last year, there were 3 bigger studies, real life studies, which were published. And in the next 10 minutes, I'll be discussing their 3 studies. The importance of this study is the first study, Myconox study, is a Flatiron data of USA. So it contains USA real life. Second, Flower study consists of European. It was an Italian study. And the third study, OCFECT, was a East Asian study. So I'm including all the patients all around the world. And what you will see is consistent improvement in the progression-free survival. But I will like you to be careful, because there was some difference in the progression-free survival, somewhat some other endpoints. But the most important thing was that toxicity was something different. Why I should do a real life study? So there are multiple advantages: lesser time, lesser resources, lesser cost. More importantly, we can know the natural history of the disease in those all comers. We can include a high-risk patient. For me, the most important thing is side effect profile. What you see in real trial are a subset of patients who are fit, but what you see in a real life. So you have some new data or some atypical side effects that I will be discussing, which I don't think I have seen in osimertinib in the Indian population. So let me start with my first study. This was a real life study, which was called as Myconox study. So basically, Myconox study consists of reports the demographic and clinical characteristics. Please remember, real world trying to next treatment and death and real world time to treatment discontinuation. This was the main endpoint for all those patients who received this drug in the US. So the importance of this study is it helps to understand the disease presentation and treatment outcome for patients with EGFR mutation in USA. Now, when you look into it, it was a Flatiron data. You remember palbociclib, we discussed a lot of times. So this was a Flatiron health records for 2 years. So from April 1 to March 31, and the final analysis was done as on June 30, 2020. So 2-year data. Let's see the important thing. Median age was 70 years. Probably in India, it is lesser for whatever I have read, between 5 to 6 decades. What is more important is 35% of the patients were more than 75 years of age. Of course, predominant females, whites, and most of them were treated in the community setting. Now, when you look into the two endpoints that they discussed rigorously was a real-time time to next treatment and death, which included death, and the other was real-time time to treatment discontinuation. Again, most of them were stage 4 disease. Never smoker were more commoner. Up to 3 metastatic sites for around 80% of the patient. And what is more important that I want to discuss is de novo brain mets were present in 33% of the patients. So a higher number. These are all commerce patients, so a very high number of CNS mets. And if I will tell you in the Asian and the European, this number is equally high. So de novo 30 to 35% have brain mets with this subset. Around 10% were uncommon mutation and 90% were a classical mutation. More importantly, around 18% of them, if you see, once they progressed, around 18% of them were able to undergo a second-line treatment. At the data cutoff, around 58% were still on treatment. But what was important is around 1/5 of the patients die and are not able to go on to the second-line treatment. Again, re-emphasizing that you should give the best drug in the first line, because even anywhere, half of the patient may not go on to take the second-line treatment. You remember your FLAURA, around 30% were able to undergo the second-line treatment overall. Now, when you look into the event, this is the first, around 38% events in time to next treatment and death. 50% had died and 50% went on to the second line. It was acceptable, 17.9. Now, when you look into the factors which tells us if the disease will do bad or not, stage 4 bad, non-smoker better. Carlton comorbidity. So if you are comorbidities, your result may not be good. If you have uncommon EGFR mutation, probably osimertinib is not the drug. Again, re-emphasizing in this Flatiron studies. And if you have a high metastatic burden, you will still do poorer. Now, when you look into the real world time to treatment discontinuation, 42% event, 50% death, the median was 17.2, again acceptable. Around half of the patients switched to second line and half of the patient died. Now, when you look into this in the multivariate analysis, a poor performance status did bad, uncommon mutation did bad, a poor performance status did bad, a highly metastatic, so more than 4 or up to 4 did bad, and presence of liver mets did well. So one of the thing is uncommon, you may not use this drug. Even in the real life, it shows that probably osimertinib may not be the best drug. So the first take-home message from this Flatiron Mykonos was, post or less osimertinib, it behaves the same way as we expect in the FLAURA studies, and we don't have a long-term outcome. The second real-life study was a FLOWER study, which was done by the Italians. So it covered 9 centers in Europe. It was an observational, prospective, multi-center study for those taking osimertinib in the first line. Again, look into the median population, 70. So probably whether Indians are earlier diagnosed or they have a median age earlier, there also it was de novo brain mets 30%, stage 4 presentation majority. Now, when you look into inclusion, exclusion, the same criteria, here the main endpoint was time to treatment discontinuation, and the other endpoint that we know, OS, PFS, ORR. Now, when you look into it, patient with poor performance status, comorbidity, rare mutation, active brain mets were included. What you got was there was no difference in PFS, time to treatment discontinuation, or overall survival in elderly less than 75, more than 75, patient with a comorbidity score of 3 or less, and less common EGFR. The time to treatment discontinuation was 25.3, so probably better than the FLAURA study. better in those with less than 3 sites and those with the isolated progression. Now, when you look into primary time to treatment discontinuation, if you don't have any symptoms, see the second part of my graph. No symptoms, the PFS had time to treatment discontinuation was not reached. Similarly, if you see the second part of the curve, so if you are less than 3 sites, again your median the time to treatment discontinuation was not reached. Now, when you talk about what about the high risk, so symptoms, no symptoms by itself was a important thing. Secondly, when you look into the sites less than 3 and 4, see the p value less 0.036 and 0.025. So if you have a lesser tumor burden, you may do well. And third one is de novo brain mets. Yes, your PFS changes. Your PFS is poorer if you have a de novo brain mets. What about responses? So 96% disease control rate. Moreover, more important is, yes, in the absence of brain mets, your PFS was very good. Similarly, if you see no symptoms at diagnosis, again, your OS was very good. So again, the second and third part of, so no symptoms, no brain mets, probably the PFS is the best. So one more thing that was said was those patients who progressed on EGFR, what was the common mutation found? So the commonest was MET amplification that we also see. MET amplification with EGFR amplification, both only EGFR amplification and HER2/neu. So probably you did not see that PIK3 or HER2/neu mutation, but these were the commonest 4 things which they found out for those who progressed on osimertinib. This is the most important thing I will like you to listen. We know about side effects like interstitial. Try to concentrate on the second part. ILD, diarrhea, stomatitis, these are commoner, but 2 to 3. But they found 7.9% with venous thromboembolism as a grade 3 side effect. In fact, I have not seen, but this was more commoner in European. So what they suggested was probably a higher incidence of venous thromboembolism as compared to any other real life studies. But they could not point out what were the patient where this was more. But yes, this was something that was new for me. In European, the highest grade 3 toxicity was venous thromboembolism. But there was no difference in survival outcome as far as what I have told, age, comorbidity, type of mutation. So this also told Europe, I could take out 2 points was that it was all equal, but yes, venous thromboembolism was more. The third and the last real life study that I'm presenting from the East Asian country by Iwai Sakata and his group, OC-FACT study. Now this studied the real life studies in this country, in this part of the world. Again, the inclusion and exclusion criteria were more or less the same. So first line, osimertinib in this subset of patients. Again, look into the population, 71 years of age, more than 75, 37% of the patients. I will like you to concentrate on, again, the primary endpoint was PFS. In other two, it was time to treatment discontinuation. And the secondary endpoint was OS and the other response rate. The median progression-free survival was 20.5 months. So again, 18.9 versus 20.5. So as good as what we have seen in the Steidl-Flora study. Now, what are the factors which determine survival? So male gender bad, effusion and liver mets bad. Again, advanced unresectable. So probably that 4 or more was bad. Now, I will like you to concentrate on the last part. Those with a TPS, they have tried to correlate, and those with a TPS of more than 50 did the worst among the two. So probably it was like the other way around. If your TPS score was less than 1%, you had the best survival, and your TPS score or more than 50, you had the worst survival. So again, telling that immunotherapy should not be suggested as one of the options in these driver mutation positive, and this was reiterated by this study from East Asia. One last thing. Around 44%, now they have told about treatment discontinuation. So 44.3% discontinued due to disease progression. But what was more alarming was 1/4 of the patient discontinued due to pneumonitis. Now, probably this pneumonitis is supposed to be an interstitial lung disease, I believe, because such a high level in a percentage of drug patients discontinued drug due to, out of 219, around 25.6% discontinued due to pneumonitis. This was something that I also found a bit atypical. When you look into the onset of these symptoms of these pneumonitis or grade 3 non-hematological, it was 56, so 53 to 56. So second month at the end, you may get these side effects. So the conclusion of this was a very impressive response rate, a very good disease control rate of 94%, time to treatment failure 19.1, very good. the median time for the start of treatment to the onset of this non-hematological adverse effect was 53 days. But what was more important was a higher degree of pneumonitis as against the other two parts of the body, probably an interstitial lung disease. Now, why it happened, we require a further investigation. So I have covered about the 3 studies. So if I have to summarize my presentation, 3 real-life data, a big study is close to 500 patients, 200 and 300 patients. They all demonstrate that efficacy seen in FLORA, and that these studies are more or less the same, so consistent with the real-world population. What has been added on by this is those patients who were not taken in those studies, like untreated or the brain met, they were included in that studies, and the responses were as good, as effective as those without a brain met. So probably you can give it in all comers. Only thing I will like you to be basically a discussion point is that the side effect profile was different in European as compared to Asian, as compared to US, and probably that needed to be studied further. I thank you all for a patient here.
Thank you so much, sir, for this extensive talk. For next talk, I would like to invite Dr. Akhil Kapoor, who is a senior medical oncologist at Tata Memorial Center, Varanasi. And his talk will be on experience sharing on durvalumab in extensive stage small cell lung cancer. Akhil sir, you can start sharing and start the talk.
Sure. Thank you, Ajay. So we are looking in a scenario where we have now some good options. After 3 decades of the treatment, we came into a scenario where the immunotherapy added to the survival benefit. So we'll start with a case. This is an experience sharing case. So definitely I will let you know about the case. So this is a 35-year gentleman who presented in June 2020. Patient had the symptoms of change in voice. There was a clear smoking history. The patient was diagnosed to have vocal cord palsy. Patient underwent a CT scan of the brain and chest, and he was found to have a left apical segment soft tissue mass. There were associated multiple nodes, and there was mass was compressing left pulmonary artery. So the patient was initially started on ATT. So this is what happens in the real world. Most of the time, the lung masses are thought to be related to tuberculosis in India, and this is a very important thing that is needed to be educated to our physicians, general physicians, that proper investigations should be undertaken before starting ATD, and not every lung disease is tuberculosis. That needs to be taken into the account. So the patient developed an episode of seizure as well, and was started on anti-epileptic drugs as well. And a follow-up MRI brain showed a brain lesion, right, temporal lobe lesion. And apart from it, there were multiple sub-centimeter lesions as well. And repeat CT thorax were done. That was high resolution. There was a left upper lobe clear-cut mass with mediastinal extension, and along with associated consolidation. You can see then the next step PET scan was also done, and this is a large mass with you can see a large significant uptake of the FDG. If you can see this mass is there, and along with this, you can see here the lesions are paravertebral lesion is also present apart from this, and this is the brain lesion. You can clearly see the lesion in the temporal lobe. So the biopsy was done, and it came as small cell neuroendocrine carcinoma with PDL of TPS 3 to 4%. Final diagnosis was extensive stage small cell lung cancer with brain metastasis. The patient, let's see what are the next steps that can be taken. First step is brain radiation followed by systemic treatment, chemotherapy alone, or chemo plus immunotherapy. So we had only few options previously, chemotherapy and radiotherapy. Immunotherapy was added in our armamentarium from last 3 to 4 years, and that has made the difference. Let's first discuss about the treatment of the brain. So this is a nice review of the treatment of brain metastasis, and this is a multidisciplinary panel of the European experts which gave the conclusions, and they recommended that the patients who are symptomatic, whole brain radiotherapy followed by chemotherapy was the most common recommendation. Asymptomatic patient, there is a high preference to start chemotherapy without whole brain radiotherapy. And even if patients have symptomatic mets with limited extent of brain mets, some experts will choose SBRT as an alternative to whole brain radiotherapy in the plan to decrease the cognitive dysfunction. So let's see. What this patient understood. Even in this patient, for the NCCN guidelines suggest that when patient is symptomatic, the patient had an episode of seizure, so it will considered a symptomatic brain met. The patient should undergo radiation, and this is what happened in this patient as well. So chemotherapy, there have been multiple studies. EP has stood the test of the time. It can be cisplatin etoposide or carboplatin etoposide. It has been tried against various regimens, CAV regimen, which is the early very commonly used cyclophosphamide, doxorubicin, and vincristine. But due to doxorubicin, there was significant mucositis, and the difference in the outcomes are not there. So therefore, many regimens came and went. Even the addition of bevacizumab did not lead to any difference. Addition of ipilimumab also not led to any improvement in the survival. So with this, the patient was given a brain radiotherapy, 30 grade 10 fraction, which is the most common way. Also, some radiation oncologists prefer to use hippocampal sparing RT. This is feasible. And the patient was started on chemotherapy as well, cisplatin plus etoposide. If we see the NCCN recommendations, the last year recommendations clearly state that based on the available data, carboplatin plus etoposide plus atezolizumab is an option. The same caro plus etoposide plus durvalumab is an option. Here you can go 4 cycles followed by maintenance durvalumab. In cisplatin plus etoposide, there is a data for durvalumab only. There is no data for atezolizumab. And here 4 cycles followed by maintenance durvalumab. In this study of atezolizumab, the patients received 4 cycles of atezolizumab with chemotherapy, that was including only carboplatin followed by maintenance atezo. So if we see this principles of radiation, this we have already discussed. So usually 30 grade 10 fractions, the most common preferred protocol. This is based on Dutch CREST trial as well. And also the consolidative thoracic RT is considered beneficial in selected patients. So this is an important thing. Patients who don't have extracranial, extrathoracic disease might benefit from the use of consolidative thoracic RT. So that is another point which should be kept in mind. And this is an important point which should be noted. Now the patient received 2 cycles of chemotherapy. The patient had already received whole brain radiotherapy with hippocampal sparing. From the cycle 3, durvalumab was added and was given at dose of 1500 milligram every month. If we see what is the rationale of combining immunotherapy in small cell lung cancer, what happens? Chemotherapy induces tumor cell killing, and this tumor cell killing will lead to circulation of the tumor antigen into the circulation, and the immune system will be primed to it. And PD-L1 overexpression leads to immune cell invasion and T cell invasion, and that becomes T cell energy. Energy of the T cell can be inhibited by using the PD-L1 inhibitor. That is the premise. And due to this PD-L1 inhibition, the T cells can work and lead to development of further activity against the released antigens. So with this, Caspian study was planned, and you can see this is a big study of 805 patients with including 0 to 1 PS patients with life expectancy more than 12 weeks and at least 1 target lesion identifiable by RECIST target. And the patients could receive either cisplatin or carboplatin, and the trial was stratified for that as well. In the induction phase, patient received investigator's choice cis or carbo with 4 cycles, and Imfinzi was given along with it, followed by 4 weekly Imfinzi till progression. In the standard arm, the EP alone was used. Also, if we see the primary endpoint of this study was overall survival. So this is another important point. The endpoint was hardcore. Sometimes we get PFS, but we don't get OS. Here, the endpoint itself was OS. So there is no confusion that PFS is reached, but OS is not reached. But here, the endpoint is itself OS. So there's no confusion about that. So the main things that I need to highlight here is the Caspian study allowed for the choice of platinum-based treatment based on the investigator choice, can be cisplatin or carboplatin. Patients with asymptomatic or treated brain mets both were allowed in the study. The control arm was also allowed to receive up to 6 cycles of chemotherapy, though the study arm received 4 cycles of chemotherapy plus immunotherapy. However, the control arm had two main differences of very important points, that up to 6 cycles of chemotherapy was allowed and PICI was also allowed as per the investigator's discretion. So these are the two important points which I have just highlighted, that in this trial also shows which is a difference, clear difference from the IMpower 133 atezolizumab study. So definitely, this is an important point, that it is reflective of the real world clinical practice, where we can choose either cisplatin or carboplatin on our choice, and also PCI can be considered in the patients who have received who are receiving only chemotherapy. So these are the salient aspects which I told was with the final endpoint, and patients of brain mets were included. Let's see the outcomes of the study. OS with brain mets, you can see with EP, it was 8.8 months. With addition of Durva, it reached 12 months, and this came as theoretically significant, but statistically it was crossing 1 point, the hazard ratio of 1. If we see the OS without brain mets, again, you can see the difference is sustained throughout, and this is reflected by the hazard ratio of 0.74. And it again, what is the difference? You can see that it is not crossing 1. But why there is significant difference in OS with brain mets, but still it is not reached statistical significant? You can clearly see the numbers. The numbers were small, 28 and 27, and here 240 and 242. That clearly tells the trial was actually powered for the overall population, not with the brain mets population. That is, ANSYS patients with brain mets were smaller in number. That is why, though there was significantly numerical benefit, but it did not reach a statistical significance. But I can clearly tell on this basis we should not exclude the patient, because it seems that these patients are also getting benefit. So the progression-free survival, you can see at 1 year, 5.3% versus 18%, at 18 months, 3% versus 14%, and at 2 years again, 3% versus 11%. So at 2 years, survival is improved from 3% to 11%. So long-term data is also clearly suggesting that the survival benefit is persistent, and it is causing a significant improvement in the outcomes. So that is a point. 10% of the patients are continuing treatment at 3-year data cutoff as well. And you can clearly see 3 times more patients are alive at 3 years, 5.8 versus 17.6%. So if we see the subgroup analysis, we are very happy to say that all the subgroups are towards the left. Sometimes it might not be able to reach the statistical significance, but here you can see all the subgroups are suggesting benefit of durvalumab addition. And definitely both patients over 65, former or active smokers, patients with brain mets, cisplatin or carboplatin eligible, all are getting benefit. Confirmed objective response rates is also, you can see the odds ratio of getting responses is also increased by 1.5 times. Again, the duration of response in the responders is, you can see the difference is significant, 5.1 months. And if we see, Imfinzi is the first approved IO to improve both the response rates and durability of the response at 2 years. If in our patient, we see the patient had a follow-up PET scan, and you can clearly see the patient had a very good response, and the brain lesion is also significantly responded, and the patient had decreased in photopenic area in the right parieto-temporal lobe. So definitely Imfinzi is the only IO presently with the clinical trial data which has supported a 4-weekly maintenance dose as well. So this is another important point which needs to be considered. That makes it very easy for our patients for follow-up. Otherwise, sometimes patients become tired of the treatment and they stop taking the maintenance treatment. This is an important drawback of the maintenance treatment, the patient's compliance. And if we can reduce the frequency where it was allowed in this study to use 4-weekly maintenance treatment, that is clearly shows that it is. Let's see the cost effectivity as well. So if we see this treatment with Imfinzi plus EP, it added 1.14 life years and 0.84 quality of life years compared to treatment with EP alone. So this is in terms of the US data, the Imfinzi is able to add cost-effective life. So to conclude, this combination of durvalumab plus EP has shown sustained improvement in the survival with a robust control arm that was powered to receive 6 cycles of chemotherapy and PCI as well, but this was not allowed in the IMpower study. And benefit with durvalumab was observed across all the subgroups, including brain mets group. So another important point, it offers convenient 1 monthly dosing, and safety analysis remains consistent with the safety known safety profile of IO drugs. With this, I stop here. Thank you.
Thank you, sir, for this interesting experience sharing. So we'll move on to our next session, that is approach to mediastinal mass. And for this, I would like to invite Dr. Virendra Tiwari, sir, who is a senior surgical oncologist at Tata Memorial Hospital in Mumbai, and he will discuss regarding the clinical aspect to clinical approach to the mediastinal mass. Virendra, sir, you can start.
Yeah, thank you, Ajay. Thank you very much. I would like to share my screen first. Is it visible?
It's visible and audible.
Okay. Thank you, Ajay. So thank you for the invitation. Our topic that we are going to discuss today or touch upon brief is how to evaluate a patient who presents to our OPD with a mediastinal mass. So we have a classes today as well as tomorrow. Management of each of these rare malignancies like thymoma, lymphoma, or other malignancies treatment will be discussed by in other classes. This is just how to evaluate or how to proceed with diagnosis or workup of a patient presenting with a mediastinal mass. So if we see what is the mediastinum, it's a very well protected space, that is space between 2 pleura extending cranially from thoracic inlet and caudally till diaphragm. We have a 4-compartment. We have a 2 important classification system. One is one which divides mediastinum into 4 compartments, and another which divides it into 3 compartments. Both are widely used, but 3 compartment is more preferred compared to 4 because it's being less complicated. So if you see 4 compartment system, it has divided mediastinum into superior, anterior, middle, and the posterior. Whereas if you see 3 compartment, it is anterior, that is prevascular, middle, that is visceral compartment, and the posterior, that is paravertebral compartment. And this was described in detail recently in 2070s by International Thymic Malignancy Interest Group, where they have defined boundaries based upon CT scan. So this is the, it is very important to know where the mass is located, because there is no simple or single uniform standard approach as far as medicinal tumors are concerned. It is a very clinically oriented approach. So a lot of factors or things play a role in diagnosis and management. Important things like age, sex of the patient, what is presentation, and what is the location. So that is why it is important to know in which compartment that tumor is located. So prevascular, that is anterior compartment, if we see, it is bounded superiorly by thoracic inlet, inferiorly by the diaphragm. Anteriorly, it is sternum, and laterally, it is obviously pleura. Posteriorly, it is bounded by anterior aspect of pericardium. And important structures that are there in this compartment are thymus, fat, various lymph nodes, various group of lymph nodes, and obviously vessels. That is left brachiocephalic vein. If we see visceral compartment, again, superior and inferior boundaries are same. Anteriorly, it is the posterior boundary of prevascular compartment. Posteriorly, it is an arbitrary line which is 1 centimeter posterior to the anterior border of vertebral bodies. And important structures that lie in this compartment are vascular as well as non-vascular, like trachea, carina, esophagus, and heart and vessels tending to heart. If you see paravertebral compartment, that is posterior most compartment, again superior inferior are same. Anteriorly, it is same, that arbitrary line. And posterolaterally, it is vertical line against the posterior margin of chest wall at the lateral margin of transverse processes. Important structure that lies in this compartment is thoracic spine, paravertebral soft tissue, and nerves. This is a pictorial representation of 3 compartments. Violet color represent anterior, that is prevascular. Blue represents middle, that is visceral compartment, and yellow represent posterior, that is paravertebral compartment. If we come to differential diagnosis, it varies according to age, according to sex also. So in younger age group, if you see female, most common diagnosis that fits in anterior mediastinum is lymphoma, followed by thymoma. The differentiating feature between male and a female is as far as regarding germ cell tumor. Germ cell tumor is more common in male compared to female, whereas others like thymoma and lymphoma are important differentials in younger age group. If we see age beyond 40 years, again, predominant tumors that patients present with is a thymoma, followed by thyroid tissue, and next comes lymphoma. So more differentials we have as in anterior mediastinum, whereas middle and posterior mediastinum, there are relatively less differentials. Middle is usually because of embryonic cyst, whereas or tumors arising from visceral structures like vascular tumors from heart or major vessels. Posteriorly, it is either spinal tumors or neurogenic tumors like schwannoma or neurofibroma. If we see clinical presentation, most commonly patients are incidentally detected when they undergo evaluation or CT scan or chest X-ray for some other reasons, like nowadays for screening CT scans. That time we diagnose most of these mediastinal tumors. So most are asymptomatic, around 50%, but few present with symptom also, and most common symptom is cough or dyspnea. These symptoms are mostly because of compression or infiltration of adjacent organ, or sometimes we have a paraneoplastic syndrome, that is myasthenia gravis or hypogammaglobulinemia or pure red cell aplasia associated with thymoma. So common presenting features are like cough, chest pain, fever, and dyspnea. Some of the patients present with life-threatening symptoms also, like superior vena cava obstruction, features of superior vena cava obstruction. There may be airway compression because of large anterior mediastinal mass compressing your airway, or there may be dyspnea because of significant pleural or pericardial effusion. It is important to identify these symptoms early, because most of these tumors or most of these symptoms can be taken care of easily, and these tumors are also curable. So if you see these pictures, the picture on the left represents a large mass with significant left pleural effusion, and obviously patient presented here with dyspnea. So this symptom can be easily tackled if you put or drain that pleural effusion either with pigtail or ICD. And the second picture, if you see, there is a mark which shows a left brachiocephalic vein which is completely compressed, and you cannot identify where the superior vena cava is. So these kind of symptoms, if you obviously patient presents with the dyspnea or facial plethora, facial puffiness, and important is to diagnose them early so that you can initiate treatment, and there is a significant relief in the symptom if treated. So it is important to diagnose and manage these kind of symptom. One of the main problem that we face is to obtain diagnosis. So tissue diagnosis is not mandatory as far as mediastinal tumor are concerned, which we'll cover again in further slides, but it is important to take care of these symptoms. So if you if you go further and see how the patient presents with, so mostly it is, so for as far as clinical evaluation is concerned, it is important to get a proper history of the patient. Age and sex is important, as we have already discussed. Differential changes according to age as well as male or female sex. So if you see history, effort tolerance is important. Patients with dyspnea will have very poor effort tolerance. They may have a symptoms of orthopnea or dyspnea also. History of undescended testis or any scrotal procedure that he has undergone outside. Or it is important to inquire about features of paraneoplastic symptoms like ptosis, diplopia, and dysphagia. These symptoms can lead you to a particular diagnosis. It is important to examine neck, especially for nodes or features of superior vena cava obstruction. It is important to identify or examine other peripheral nodal compartment like axilla or inguinal, which can be there, like lymphadenopathy can be there in cases of lymphoma. Per abdominal examination is again important. There may be a splenomegaly in hematolymphoid disorder, or there may be a large nodal mass in germ cell tumors. Testicular examination is important, again to look out for a germ cell tumor. If we see radiology, CT scan is the gold standard. Most of the patients usually to our center present with a CT scan. And we may not need any further investigation if he comes with a good contrast enhanced CT thorax. We may need MRI if there is a doubtful neurovascular infiltration, or if we see some cardiac infiltration on the provided CT images. Posterior mediastinal masses, we may ask for MRI sometime if there is a doubt of spinal extension. Again, MRI has an important role in thymoma. Chemical shift MRI can differentiate hyperplasia from different types of thymoma. PET scan is not mandatory, but it is used for staging in lymphoma, and obviously high-grade thymic tumors where the metastasis is more common, like thymic carcinoma. PET scan is again used for a response assessment after chemotherapy. And different WHO grading can also be done with PET-CCT. So this is a picture of a patient presenting with anterior mediastinal mass. Diagnosis was non-seminomatous germ cell tumor. Here on CT scan, we had a doubt about cardiac infiltration. If you see right atrium, tumor is abutting and there is a loss of fat plane with the atrium. But when we did MRI, there was a good enough plane and we proceeded with surgery. So these are the few areas where MRI is helpful. Again, posterior mediastinal mass where we had a doubt of spinal extension, we did MRI and found the same. As far as diagnosis is concerned, what I have already told, we do not need biopsy in all cases. History is important thing. Another important laboratory investigation that can lead you to diagnosis is a serology. So if a young patient, that is 10 to 39 age group of patient present with the anterior mediastinal mass, male patient, we should have a high index of suspicions for germ cell tumor. So our simple blood investigation for a tumor marker like alpha fetoprotein beta HCG can lead you to a diagnosis. LDH again is a non-specific marker. It is high in germ cell tumor as well as in lymphoma. If you are suspecting thymoma, that is a patient who presents after 40 years of age with anterior mediastinal mass, relatively homogeneous mass on CT scan, it is important to ask for features of paraneoplastic symptoms and also to get an acetylcholinesterase receptor antibody. This is important in diagnosing paraneoplastic syndrome and also will be important in management if patient has a myasthenia. Biopsy, if there is a characteristic clinical feature, and like in anterior mediastinal mass with features of myasthenia, we do not need a biopsy. Again, if there is a classical features of teratoma, that is mass with fat and ossification or calcified like tooth or bone fragments, that is suggestive of teratoma, we do not need diagnosis biopsy. If your serum markers are conclusive of non-seminomatous germ cell tumor, again, biopsy is not needed.
Excuse me, sir.
Present with anterior mediastinal. Hello?
Excuse me, sir. If possible, try to finish in next 1 minute, sir.
Yeah. I'm almost done. So again, here, if you have a strong suspicion of thymoma and lesion is resectable, you do not need a biopsy. But if there is a differential between, so mostly you can avoid biopsy based upon your radiological and clinical feature. But if there is any doubt, it is important to have a biopsy and then only proceed. CT guided biopsy has a good yield. We may need PET guidance to sometime there, if the tumor is very large, there may be a necrotic component. We may go for a PET to guide our biopsy. It is very rarely we go for a surgical biopsy like VATS, mediastinoscopy or thoracotomy. And as far as other clinical evaluation for mediastinal tumor is concerned, it is important to get a functional evaluation if patient is planned for surgery. Functional evaluation is same as we do for any lung procedure, that is PFT DLCO. VQ scan may be needed if you think that the diseased site or the lung is not functional, so that your whatever PFT or that is FEV1 or DLCO is there, it is contributed by the functional lung. Sometimes if PFTs are not good, we go for a low technology exercise test or CPET. Thank you.
Thank you so much for this covering extensive topic in short time. For the next talk, I would like to invite Dr. Suman Kumar, who is a senior radiologist at Tata Hospital, Mumbai. to cover the radiological aspect of mediastinal mass.
Thank you.
Dr. Suman, sir.
Hello, can you hear me?
And one more, if anyone having a question, please put in the chat box so that we can discuss in these questions in the session after this. We have 3 to 5 minutes to discuss the questions for the current session in the after this talk for 5 minutes. Thank you. Sir, you can start.
Yeah, am I audible?
Yes, sir.
Yeah. Good evening, everyone. Today, my topic is the diagnostic approach to mediastinal masses. Dr. Virendra has covered extensively, and he has made my job easier. He has covered the radiology part also, so it will be like a revision again. So the today's learning objectives are to identify the boundaries and contents of the mediastinal compartment and understand the basic approaches to diagnosing mediastinal masses based on the imaging features, and also describe the role of imaging modalities. So according to the ITMIG International Thymic Malignancy Interest Group classification, the mediastinum has been divided into anterior, prevascular, visceral, and paravertebral compartments, which we traditionally call it as anterior, middle, and posterior mediastinum. And the purple color is the anterior mediastinum, the blue is the middle mediastinum, which contains the vascular and airways and the major vessels, and the spine, thoracic spine, and the paravertebral soft tissue is included in the paravertebral compartment or the posterior compartment. So the International Thymic Malignancy Interest Group has standardized the scheme to describe the mediastinal compartments, and it has used the modified Japanese Association of Research on Thymus model, and to simplify the classification of the mediastinum, which has been covered previously. The boundaries are superiorly thoracic inlet and inferiorly diaphragm for all the compartments, prevascular, visceral, and paravertebral. The important thing to remember is the major contents of each compartment and the lesions which will arise from these organs will help us in narrowing the differential diagnosis. And the various imaging modalities which use a radiography, MD-CT, MR, and FDG. X-rays we are not using routinely to diagnose a mediastinal abnormality, but they are the first line of investigation, and incidentally you see a lesion and then obviously you ask for MD-CT. But we try to narrow down the differentials based on the imaging findings on an X-ray, and then ask for a multi-director CT, which is a gold standard. And the MR is always a problem-solving modality to see if there is any cardiac involvement or the paraspinal extension. And FDG PET is used in specific conditions like to detect lymphoma or to see if there is any malignant transformation in a benign neoplasm. So anterior mediastinum or the prevascular compartment, the posterior border of the sternum to the anterior part of the anterior surface of the pericardium and the trachea and the great vessels. The contents are, like I said, thymus, lymph nodes, adipose, and internal mammary vessels, and the thyroid gland if it extends into the mediastinum. So it is traditionally considered as a superior mediastinal structures, but the retrosternal goiter is a mass seen in the anterior mediastinum. So the differential diagnosis are based on the organs which we see in the anterior mediastinum. Thymoma, thymic lesions are the most common lesions in the lymphadenopathy and lymphoma, and the paracardiac masses, and the rare lesions or the lymphatic malformations. So I'll start with a radiograph and show how the various lines and stripes will help us in identifying these to locate the abnormality of the compartment. So this is the anterior junctional line, which is the opposition of the pleura of the both the four pleural surfaces, which is seen as the anterior junctional line. So this on CT is the anterior junctional line, which is seen below the sternal notch. So when this is disrupted, then we can think that the lesion is arising from the anterior mediastinum. The hilum overlay sign is to narrow down the mediastinal mass, mediastinal mass, whether it's arising from the anterior or the posterior mediastinum. When we can see the hilum through the mass, then that is the hilum overlay sign, where the hilum is not disrupted. Then that says that the lesion is not arising from the middle mediastinum. And the descending aortic stripe is clearly seen. So we can say that the silhouette of the descending aorta is maintained. So this is not a posterior mediastinal structure, but an anterior mediastinal structure. So the CT of the same shows a anterior mediastinal mass, and this is a lymphoma, which is and through which the hilum is seen behind the mass. And this is a right paracardiac lesion causing this loss of silhouette of the right para-aortic shadow. So this is a anterior mediastinal structure, and this is having a low density. So this is most likely a fat, pericardial fat, so epicardial fat pad. And this is a mediastinal mass extending into above the sternoclavicular joint with the indistinct lateral margins of the. So we call this as a cervicothoracic extension, and this is most likely anterior mediastinal mass. If at all, if the lesion lateral borders and the middle borders are clearly seen, lateral borders are clearly seen, it is a posterior mediastinal structure. Otherwise, it's anterior mediastinal structure. So this is a thyroid mass extending into the superior mediastinum. So to see some examples of the anterior mediastinal masses, this is a large soft tissue lesion in the anterior mediastinum with cystic necrotic areas, and few calcifications are seen. This is a retrosternal goiter, and this is a mediastinal mass showing fat density and soft tissue density. So the mass is predominantly fatty. So this is a mature teratoma. Sometimes bone or well-defined structures can be seen in, and which clearly identify this as a teratoma. And this is a soft tissue, the predominantly fat-containing mass with soft tissue areas within. This is a thymolipoma, and this is a well-defined fluid attenuation lesion in the anterior mediastinum, which on MRI shows a T2 hyperintense well-defined lesion with no septation. So this is a simple thymic cyst, and this also looks like a thymic cyst with enhancement of the walls, and which on MRI shows a cystic structure with internal septations within. And this is a, and the walls and the internal septa are enhancing. So this is a cystic thymoma. So we can confuse this thymic cyst with the cystic thymoma. With the clinical correlation, the patient presenting with a myasthenia gravis, and on MRI there is an internal enhancement of the septa, will narrow down the diagnosis to a cystic thymoma. And there is a large, well-defined fluid attenuation lesion with not much mass effect. This is a pericardial cyst, and a large fluid containing lesion with multiple septation extending into the neck or in thorax can be lymphangioma. So this is a is anterior mediastinal mass with lobulated soft tissue lesion in the anterior mediastinum. On MRI, this is the in phase and this is out phase. So we can see this is the on in phase, this is appears bright, and on out phase there is a loss of signal. So this is a fat containing anterior mediastinal structure. So this is a thymic hyperplasia. So the fat here is the clinch, though in thymic hyperplasia, where if there is enlargement of thymus or due to any stress, then the fat containing, if there is an inherent fat, then this is a thymic hyperplasia where we can just observe the patient without subjecting him to the biopsy. And this is a soft tissue lesion in the anterior mediastinum, and with no fat, or we can see it's a predominantly soft tissue lesion, well defined. So this is, and this can be confused with a benign, or which can be confused with a thymic hyperplasia, but with a clinical history of myasthenia gravis, then thymoma can be suspected. And this is again anterior mediastinal structure mass with infiltration of the pleura. So this is a thymic carcinoma. So if there is a mediastinal mass with inherent calcification or cystic areas, then that can be invasive thymoma rather than a thymic carcinoma. Only in case of a metastatic setting, we call it as thymic carcinoma. This is a large anterior mediastinal mass lobulated, aborting the vessels with no mass effect. So this is a, and the PET shows a very high uptake. So this is a case of lymphoma, and after one cycle of chemo, there is a marked decrease in the PET uptake. And this is a mature, this is a seminoma in a 39-year-old male, and this is a non-small cell germ cell tumor presented with the pleural effusion. So to identify these lesions as a germ cell neoplasms, we have to correlate with the clinical and biochemical findings. And in this patient, in NSGCT, there was an increase in alpha fetoprotein, which pointed towards the NSGCT. And the middle mediastinum visual compartment, as said, there is the vascular structures and the tracheobronchial tree and the great vessels are included in this one. The visual compartment contains are heart, vascular and non-vascular, as mentioned. And the most common mediastinal masses are again lymphadenopathy, aortic arch aneurysm, duplication cyst, pericardial cyst, and tracheal lesions. This is a paratracheal stripe, which is the interface between the lung and the trachea. And as you can see on CT, this is beyond the superior vena cava. The interface between the trachea and the lung is the paratracheal stripe. So loss of this paratracheal, right? The paratracheal stripe helps us in identification of the location. So there's a large lymph node causing the loss of the paratracheal stripe. As you can see here, there is a loss of paratracheal stripe. And this is the aortic aortopulmonary window below the aortic knuckle. And this is usually concave or straight. If at all, if it is convex, then we should suspect a node, an enlarged node in the aortopulmonary window. As you can see, there is a convex appearance. And on CT, there is a enlarged node here. So this is another mediastinal, the obliterating the AP window, and this is aortic arch aneurysm. And this is the aberrant right subclavian, aberrant superior vena cava, which can cause the obliteration of the AP window. And this is a bronchogenic cyst, a well-defined cystic structure. And on MRI, you can see there's a layering effect. On T2, there's a bright, and then on T1, there's a hyperintense proteinuria structure. So this is a benign bronchogenic cyst. And this is a esophageal duplication cyst where there's a well-defined cystic lesion in continuity with the esophagus. And there's a well-defined lesion in the middle mediastinum. And on biochemical examination, there are raised catecholamines, and in the lesion showing intense enhancement. This is a paraganglioma. And this is a enhancing lesion with a peripheral non-enhancing area. And the diagnosis was not straightforward, but the biopsy showed that this is a Castleman disease. And this is the esophageal mass in the CA esophagus.
Sir, we are overrunning the time.
Yes, yeah, I am done. Yes, and this is a cardiac mass. So posterior mediastinal structure, I'm just come to a final part. There is a thoracic spine, paravertebral soft tissue, lymph nodes, and the more the loss of esophageal recess is an indication on the X-ray. This is the bulging of the esophageal recess. This is the posterior junctional line, and this is the mass in the esophagus. And this is the posterior junctional line. This is the infection causing the loss of silout there. And this is a neurogenic tumor, which is extending below the diaphragm, and large neurogenic tumor in the posterior mediastinal mass. This is a metastatic, this is a malignant neurogenic tumor. However, it was stable, and then after 2 years of follow-up, there was an increase in size with dissection. So this is a malignant transformation, and PET-CT has picked it up. This is another example of posterior mediastinal mass, extramedullary hematopoiesis. And this is meningocele in NF1. So divisions of mediastinum to specific compartments is essential in making a differential diagnosis and planning biopsies. And these are the two main articles from which I have sourced my study. Thank you. Thank you so much, sir.
Thank you so much, sir. So we have 2-3 minutes for questions. There is one question in chat box. How, based on imaging, how we can differentiate between intermediastinal Hodgkin's lymphoma or fibrosing mediastinitis or IgG4 related mediastinitis?
Yeah,
based on imaging features.
Fibrosing mediastinitis, the age is one of the features to identify the lymphoma, age factor, and there's a large lobulated mass in the anterior mediastinum or in the mediastinum without causing compression of the vascular structures. Is more in favor of lymphoma, but sometimes it's very difficult to identify the IgG4 disease and lymphoma, and the biopsy is necessary. So CT-guided biopsy would be useful in coming to a final diagnosis.
Okay, sir. There is one more question in chat box to Dr. Nidhi Tandon, ma'am. In case of as we have discussed on durable maintenance after post CTRT, if we are aware that this tumor is EGFR or ALK mutation positive, so still will you recommend to go ahead with durvalumab?
Sorry, I don't know if I can answer this question.
No, sir, this question is for Nidhi Tandon, ma'am.
Okay.
This was discussed in our previous session. Nidhi, ma'am, are you there?
I think Ajay, I think ma'am has answered in the chat box because.
Oh, I think that was some different. But in this specific data, they have analyzed, did the subgroup analysis of EGFR and ALK positive. There was 3% in both the arm, ALK positive, and 6% of EGFR positive. And in this, they have not found any benefit of maintenance durvalumab. But as of now, irrespective of molecular marker, we are giving durvalumab maintenance even in EGFR and ALK positive subgroup. But the data subgroup analysis has shown that there is no benefit of durvalumab maintenance in this subgroup of patients. So, but I don't know whether based on this subgroup analysis we are changing our practice. But in post CTRT, if feasible, we are giving a durvalumab with respect of molecular marker. If anyone has any opinion, they can share on now, either Bharat Vaswani sir. If there is no any further questions, then I'll like to hand over to Nandini ma'am again to continue the next session.
Thank you, Ajay. We move on to the next session, which is on mediastinal non-seminomatous germ cell tumors and other seminoma. To coordinate this session, I would like to call upon Dr. Amit Agarwal from AIIMS Raipur and Dr. Gurvinder Singh from Tata Memorial Center, Sangrur, to I'm handing over the session to them.
Thank you, ma'am. Thank you. I would like to invite Dr. M.V. Chandrakant, Consultant Medical Oncology, Narayana Super Specialty Hospital, Kolkata, for delivering a talk on diagnosis and workup of patients with mediastinal NSGC. Over to you, sir.
Thank you, sir, for the introduction, and I thank the organizers for providing an opportunity to speak on this platform. Well, in this 10 minutes, I'll quickly go through the workup, the diagnosis, and the initial assessment of a mediastinal non-seminomatous germ cell tumor. Well, if you look into germ cell tumors, as the name says, germ cell is from the gonads. So extragonadal germ cell tumor is apart from gonads, that is apart from testis and ovary, we call it as extragonadal. So importantly, extragonadal is in the midline only. It starts from the pineal gland, and then it is there in the mediastinum, and then the retroperitoneum, and then the sacrococcygeal. The extremes, that is the pineal gland and the sacrococcygeal region, are usually seen in infant and children. So very importantly, these extragonadal germ cell tumors, the difference is not just the location, but also in the biology of these tumors. These tumors are biologically different. So histological components of a non-seminomatous germ cell tumor is remembered by ECTY, the embryonal cell, the choriocarcinoma, teratoma, and the yolk sac tumors. These are the histological components of a non-seminomatous germ cell tumor. Well, if you look into one important difference is immature teratoma. In adults, an immature teratoma has an aggressive prognosis, whereas in prepubertal, it has an indolent course and may be observed as well. Well, if you look into the pathogenesis of these extragonadal germ cell tumors, including the mediastinal germ cell tumor, there are two contrasting hypotheses. One is it is basically the primordial germ cells that is there in the crest have directly migrated, or other one is the reverse migration from the gonads. So the different locations of non-gonadal or extragonadal germ cell tumors are biologically different. The biological difference in the mediastinal NSGCT is that they have a poorer prognosis. Yolk sac tumor elements are more common, and they are associated with leukemia in significant number. So the cumulative incidence of a metachronous testicular cancer in a mediastinal NSGCT is 10% at 10 years. Hence, a scrotal ultrasound at baseline and at follow-up is necessary because the incidence is quite high even during follow-up. When you come across a patient with a suspicious mediastinal germ cell tumor, you must always look for the phenotypic features of Klinefelter syndrome. So 3% is the number for a testicular germ cell tumor, whereas it is 30% for a mediastinal germ cell tumor. Therefore, 1/3 of them of mediastinal germ cell tumor may have this phenotypic or features of Klinefelter syndrome. Therefore, we must always look into it. So if you look into the clinical features, the most common is around 20 to 40 years, and these are the usual symptoms: fever, weight loss, chest pain, dyspnea, and with supravenacular obstruction and gynecomastia. So gynecomastia can be because of high beta-HCG levels, or it can be because of Klinefelter syndrome also. So how do we diagnose? So the classical way of diagnosing is by a needle or true-cut biopsy. We cannot avoid biopsy in these patients. However, when a patient is grossly symptomatic with SPCO and so on, in these patients, we may start our initial treatment based on the tumor markers. Well, if you look into the diagnosis of mediastinal NSGCT, you need to remember 2 points. Number one is we need to answer, are we dealing with a germ cell tumor? If it's a poorly differentiated carcinoma, we must remember most common is germ cell. However, we must rule out the existence of a hematolymphoid malignancy, especially a T lymphoblastic lymphoma or a primary mediastinal B-cell lymphoma. These are the close differentials. And then we need to answer another question, is it a primary NSGCT or it has come all the way from testis? Therefore, a scrotal ultrasound and a staging CCT of chest and whole abdomen are necessary. And these serum tumor markers are either diagnostic or prognostic in a NSGCT. However, they are usually raised. And what is raised is usually AFP. And another important is the chromosomal abnormality, that is isochrome 12p. So isochrome is basically the replication of the same arm. Instead of there being different arms, the same arm gets replicated, and that is what is isochrome 12p. It is usually done by fish. It is seen in nearly 80% of germ cell tumors, and it is highly specific. However, it has not got any such prognostic implication as of now. So very importantly, 85% of NSGCTs have tumor markers raised, and among that, AFP is more commonly raised than beta HCG. And in a series of 600 odd patients, you can see that AFP is raised in around 75% patients, and the median is around 2500 when compared to the retroperitoneal ones, it is just 25. So the moment you think of mediastinal NSGCT, AFP is the one that is raised in around 75 to 85% patients. So in another series of 64 cases of mediastinal non-seminomatous germ cell tumor, 60% had pure yolk sac tumors. So therefore, yolk sac tumors, AFP, are more common as far as mediastinal NSGCTs are concerned. And this is how the typical histopathological appearance of a mediastinal yolk sac tumor. And hematolymphoid malignancy being present is a significant association as far as mediastinal NSGCT is concerned. And the classical type of hematolymphoid malignancy is basically a megakaryocytic or a megakaryoblast myelogenous leukemia is what we see. Other rare types like mastocytosis or histiocytosis are also seen, including MDS. And very importantly, even these hematolymphoid malignancies share isochrome 12p as the cytogenetic marker. And importantly, the postulation is that these hematolymphoid malignancies also originate from the yolk sac and then they home to marrow. So in a series of 200 odd patients, 6% is the number of patients who have hematolymphoid malignancy in patients with mediastinal NSGCT. And the time to onset is around 6 months. And they have a very dismal prognosis with an overall survival for around 5 months only. And none survived up to 2 years. So mediastinal non-seminomatous germ cell tumor is always classified as a poor risk type of germ cell tumor. And an average 5-year survival up to now is around 40%. So what are the take-home points we can have? All the extraconadal germ cell tumors are always, they are midline in location. And it is not just a location, they are also biologically different. So we have 4 different histopathological types. Yolk sac is the one that has high AFP. That is most common in the mediastinal non-seminomatous germ cell tumor. 30% of patients may have Klinefelter syndrome. And we must differentiate them from lymphoma before we embark onto therapy. Biopsy is the way to go. And we must do a CCT staging of chest and whole abdomen and pelvis. Scrotal ultrasound and tumor markers are important. Isochromosome 12p is the hallmark, which is very specific, but is either prognostic or it is required for diagnosis. 6% of them have a megakaryocytic type of leukemia. And even they have isochrome 12p as a chromosomal abnormality. And it's always classified as poor risk, and 40% is the survival at 5 years with the mediastinal NSGCT. Thanks everyone for patient listening. Thank you.
Thank you, sir, for such a wonderful talk. I would like to invite Dr. Akash Tiwari, Consultant Medical Oncology, Shelby Hospital, Indore, for his talk on chemotherapy in mediastinal NSGCT and response assessment. Over to you, sir.
Good evening, everyone. Are the slides visible?
Yes, sir. Visible.
So, first of all, I'd like to thank everyone for this opportunity. The topic of discussion today is the treatment or chemotherapy in mediastinal non-cementous germ cell tumor. Now, we have had this wonderful talk on extragonadal germ cell tumor shortly. So, chemotherapy part of mediastinal NSGCT is pretty short. It could be summed into 3 subtypes: what to give, what not to give, and why. Is there something new that we are not adopting, and how to follow up? So we know that extragonadal germ cell tumors usually happen in midline. They could be seminomas, NSGCTs, mature teratoma, immature teratoma, and NSGCT is something that is in our focus today. It was also mentioned in the talk prior that most of these NSGCTs have a yolk sac component, and the alpha fetoproteins are high. They happen in young male predominantly. They may be associated with hematological malignancies and have common symptoms similar to those associated with most other mediastinal masses, that of cough, chest pain, dyspnea, weight loss, etc. Their diagnosis is predominantly based on imaging and tumor markers. Though in all patients where a biopsy can be done safely, it is preferable to get a biopsy done. As was discussed earlier, whenever it is not feasible, especially in case with an SVC syndrome or the biopsy being troublesome or the facility not available, we can, of course, with imaging and tumor marker alone, treat these patients. Now, all primary mediastinal NSGCTs are treated as poor risk tumors. So they are aggressive tumors, they need multimodality care. The backbone of their therapy remains chemotherapy. So that era of upfront surgeries in primary mediastinal NSGCTs is long gone. As they are poor risk, they are treated with 4 cycles of chemotherapy. The only difference is that VIP is the preferred regimen when we are treating patients with primary mediastinal germ cell tumor. And this fact that VIP is preferred by most clinicians is driven by the fact that bleomycin adds to pulmonary toxicity, and a large proportion of these patients with NSGCT will undergo a surgery, a sternostomy, a mediastinal or a thoracic surgery, and hence the chances of pulmonary toxicity would be higher. And we also know from previous trial that VIP efficacy is similar to BP, and hence it has replaced this regimen in primary mediastinal non-cementous germ cell tumor. So this evidence is predominantly driven by a very large retrospective study where patients with primary mediastinal NSGCTs who had undergone thoracic surgery after chemotherapies were included. There are around 221 patients, and some of them had received VIP, others had BEP. And post surgeries, we see there's stark difference in the complications or the pulmonary complications that these people had. So the proportion of patients having ARDS in the BEP arm was 13% versus none in VIP. The increased or prolonged ventilator requirement was 18% in the BEP arm versus 2% in the VIP arm. And the perioperative death related to pulmonary failure was seen in almost 10-11% patients in the BEP arm versus none in VIP. And it is based on these data that we treat most of the patients with primary mediastinal NSGCTs with VIP, with exception of the patients where hematological toxicity take a greater precedence. There was this other trial, JETUC 13, which involved personalization of chemotherapy in germ cell tumors. So it took patients with poor risk NSGCTs. The intervention in the intervention arm, or in this group of patients, the first cycle was BP. In the 18 to 21 cycle, the tumor markers was assessed. In the favorable group, the conventional BP was continued. In the unfavorable group, they were randomized to receive either BP or a dose-dense regimen. A dose-dense regimen was horrifically complicated. The 3-year PFS in the intervention arm was 59% as compared to 48% in the conventional BP arm or the standard of care. With a hazards ratio of 0.6, it was statistically significant. Though in current practice, with a lack of survival benefit, the greater toxicity, the standard regimen or continuing with the same regimen remains the standard of care rather than intensification in patients who do not respond well based on the tumor marker assessment. Response evaluation is predominantly, as in all other NSGCTs, we do tumor marker assessment before each cycle or when the patient is admitted for the chemotherapy to look for response. At end of therapy, 4 to 6 weeks after the end of therapy, we do the imaging and tumor marker assessment. The imaging is done by CT rather than whole body PET CT, as we understand. And all is something that we'll discuss in the talk subsequently, that all patients with residual disease should be operated, even if they have, say, rising markers after the end of therapy, because when these patients relapse, they have significantly poorer outcomes of a relapsed GCT as compared to any other site. So when these patients relapse, their treatment is marginally effective. Only 5 to 11% of these patients would have long-term controls, and most of them would relapse early. There's a separate talk on chemotherapy in relapse setting, so we'll briefly touch it. So after VIP, there is no standard of care. The options could be TIP, VEIP, a high-dose chemotherapy followed by transplant, or other combinations with gemcitabine, Pacli, or oxaliplatin or cisplatin. So essentially, in patients with primary mediastinal NSGCT, the therapy with it is treated as a poor risk tumor. Therefore, all these patients receive 4 cycles chemotherapy. A VIP-based regimen is preferred over BEP, with the standard response assessment, with the change being that one has to be more aggressive with surgery in these patients as compared to the other patients with NSGCT. Thank you.
Thank you, sir. Thank you for such a crisp and knowledgeable talk. I would like to invite next Dr. Sabita Devnani, Professor Thoracic Surgical Oncology at Tata Memorial Hospital, Mumbai, to deliver a talk on role of surgery in mediastinal NSGCT. Over to you, ma'am.
Sorry, I'm really sorry. I'll start sharing my screen now. I would like to start off by thanking the organizers for giving me this opportunity. And my work has really been made easier by the previous speakers who have covered the radiology, the clinical presentation, the chemotherapy, which is the backbone of the management. So coming to my talk, which is on the role of surgery in mediastinal non-seminomatous germ cell tumors. Let's say that, surgery is needed for 2 ends of the spectrum. Seminomas are purely treated by chemotherapy, and teratomas are generally treated by surgery. So these are the 2 ends. In between are the non-seminomatous germ cell tumors, which are residual after chemotherapy, and a lot of them require surgery. So how do we do this? Let's go about it. These are rare tumors, as has already been covered in the previous talks. Most of the evidence is retrospective. There is no level 1 evidence to guide our treatment, and all this comes from consensus statement guidelines. And also we have extrapolated a lot of treatment aspects from gonadal germ cells tumors. So before we think about surgery, we also need to rule out metastasis, and we need to rule out a gonadal primary retroperitoneal lymph nodes before we go on to treat the mediastinum. So all this has already been covered: tumor marker evaluation and tissue biopsy, prognostication. We have heard multiple times in the previous sessions that mediastinal as the primary site is a poor risk factor, and imaging was very well covered initially. But as a surgeon, what would I look at in the imaging? Not only would I look at the huge mass and its planes with the important structures, such as the mediastinal vessels, the superior vena cava, the arch of aorta, the brachiocephalic veins, but I would keep an eye out for anomalous vessels, for any aberrant anatomy, for vascular feeders, and if there is any need for preoperative embolization. Otherwise, these would result in excessive blood loss. When do we do MRI? When do we ask our radiology colleagues that we need an MRI of the thorax? So it is ancillary to CECT and hasn't replaced CECT yet. It is considered in situations where there is invasion of the mediastinal soft tissue, the chest wall, if there's extracapsular extension of the mediastinal mass, if it is invading the pericardium or the cardiac chambers. CT angiography is reserved for specific situations when you want to reconstruct vessels, when you're going to resect vessels, and the role of PET-CT is not yet well defined. So these are some images from a cardiac MRI, which help us to assess the infiltration of the vessel wall, whether pericardium is involved or no, and whether we can get away with resection of only of the pericardium or even the cardiac chambers are involved. An important consideration when you're looking at the superior vena cava is whether the sinoatrial junction, where the superior vena cava enters into the atrium, is free or not, because when you are looking at tumors which are close to these vessels, you need proximal as well as distal control. Also, by looking at this imaging, we can plan for the need for cardiopulmonary bypass and vascular reconstruction. So like I said earlier, the indications for surgery, mature teratoma, upfront surgery, as these tumors are chemo-resistant. So when your tumor markers are normal and you have a huge mass in the mediastinum, you know that chemotherapy is unlikely to work. Then other germ cell tumors, surgery is considered for post-chemotherapy residual masses. Most seminomas will not require surgery. And also something that is known as the growing teratoma syndrome, where non-seminomatous germ cell tumors, which are post-chemotherapy with normal tumor markers, keep on growing and compressing important structures. So post-chemotherapy residual mass is something that is associated with the need for surgery, even if there are elevated tumor markers, as elucidated by the previous speakers. And if this pathology shows complete necrosis without viable tumor, this is associated with excellent survival outcomes. Even after surgery, if your tumor markers were high initially and you operated on a post-chemotherapy mass, but after surgery, the markers became normal, this also is a predictor of long-term survival and free from recurrence. As we know, the second-line chemotherapy is associated with poor outcomes if the tumor markers are elevated. Post the first line of chemotherapy, most of these patients would be offered surgery if they are resectable. What are the principles of surgical resection? Our basic aim is to get a R0 resection, that is to get the whole tumor out with negative margins. But this surgery is quite technically demanding because of the location of these tumors in the anterior mediastinum, where you have most of the great vessels, the important nerves, the phrenic as well as the vagus on either side. And also these tumors extend laterally to infiltrate the lung hilum in some cases. Now, most of these patients receive surgery only after chemotherapy. And the kind of chemotherapy they receive, it causes obscuring of the planes with important structures and also the tissues to become fibrotic. Most of the time, the pericardium is not infiltrated. So if the superior aspect of the pericardium is adherent to the tumor, if you resect the pericardium along with the tumor, it forms a good margin and you can get a R0 resection. We have to balance surgery. We have to spare critical structures, and we should use liberal frozen section analysis, as it is very difficult to make out what is post-chemotherapy residual disease versus just post-chemotherapy fibrosis. Resection and reconstruction is feasible for great vessels, even for the entire superior vena cava, but this has to be planned carefully and done in a high volume center where the necessary infrastructure, logistics, and expertise is available. Cardiopulmonary bypass may be required, and this must always be kept in mind. So this is a French multicentric study which showed that surgical resection in post-chemotherapy residual mass was the only factor that predicted a good survival, as we can see on the graph. And there are also other papers which are published large center, multicentric as well as single center retrospective series, where they have said that if you resect and you can get an R0, then you have a good survival. But if the tumor markers remain elevated post-surgery, if you have a histology such as choriocarcinoma, or more than 50% of the specimen has viable tumor, this is associated with poor survival. Similarly, an old study from MSKCC, which actually laid down the foundation for considering surgery in post-chemotherapy residual masses, said that there was no statistically significant differences in survival in patients who underwent surgery with normal markers compared to elevated tumor markers. So you must offer surgery even if the tumor markers are elevated and the patient has completed the requisite chemotherapy. We need to evaluate these patients pre-operatively, and this was already covered in the talk by Dr. Virendra Kumar, my colleague. So what has been the surgical approach for these tumors? Open surgery has traditionally been the preferred approach, like I alluded to the dense adhesions and also the poor planes that are seen in these masses. The tumor size, the extent of the tumor superiorly, inferiorly, laterally, as well as the deep extension is the factor which decides the surgical approach. Previous surgical attempts may have been made in the form of biopsy or just a debulking, and this history needs to be kept in mind, for especially if a previous sternotomy has been done, then to again approach this tumor through a sternotomy will be fraught with danger. So you have to keep all these factors in mind. And most of the time, as a general rule, you should start dissecting at the area where you think it is going to be have a high chance of unresectability. Otherwise, from left to right, because on the right is the superior vena cava, which is still a resectable structure as compared to the arch of aorta, which is generally unresectable. There are many approaches which have been described for these masses, and these include the median sternotomy, which is the most commonly employed approach, and the clamshell thoracotomy. And there are various variations such as hemi-clamshell trapdoor, but the posterolateral thoracotomy is hardly employed. So these are some images. The one lower down is a clamshell thoracotomy and the one on top is a median sternotomy. So as you can see, these are really large incisions which are required to approach these tumors which sit on the heart and important structures. A minimally invasive approach is now coming into vogue, and it is usually considered when tumors are confined to the mediastinum and they do not have any lateral extension. Small sized tumors with good planes can be considered for VATS. Some robotic surgery has also been tried. Multiple series have been published. But you have to keep in mind, when there are indistinct planes, infiltration of surrounding structures, you need to convert early instead of getting into trouble by causing any vascular injury. So such small tumors taken up for VATS excision can also come out to be inoperable, because as you can see in both the images, the plane with the pericardium at some point is indistinct, here at the arch of aorta and here at the pulmonary conus. So these tumors may look deceptively small, but the planes usually are quite infiltrative. So there have been a number of papers, and these describe that the postoperative outcomes are acceptable. And when we come to extended and major resection, the venous structures are the ones which require resection and reconstruction in most of the cases. So the brachiocephalic veins, the right as well as left, are commonly involved by these tumors. And if you resect unilateral brachiocephalic vein, usually a reconstruction may not be warranted if there is a good vascular supply from the collaterals. Superior vena cava, like I already said, proximal as well as distal control has to be obtained. The tumor should be resected from the left completely before you come on to the superior vena cava on the right. So you should be R0 elsewhere before considering a major excision of a major vessel. Tangential defects, which are approximately 1/3 of the circumference, the vein can be closed without any reconstruction if the primary closure is without tension, and larger defects are reconstructed with autologous or bovine pericardium. So these are some images which show SVC encasement, which is completely encased 360 degrees and then a reconstruction. We also have other important structures in the mediastinum which need to be safeguarded, and these are the two nerves, the vagus as well as the phrenic. If you injure any of these nerves, the postoperative outcomes of the patients are highly compromised, As we all know, the recurrent nerves on the left as well as the right are quite close to these masses. Even after chemotherapy, the planes with these nerves may not be great. And therefore, we have to make sure that we save these nerves, we safeguard them, and we can employ things such as intraoperative nerve monitoring. Then the phrenic nerve, like we all know, is the one which supplies the diaphragm. And we have to consider preserving both the nerves as far as possible. Unilateral resection may be feasible if the lung function is very good and you are R0 elsewhere. But if you have resected a nerve, please go ahead and do diaphragmatic plication so that the patient does not develop postoperative basal atelectasis and collapse, pneumonia. And sometimes the right phrenic nerve will be difficult to preserve, even especially when a SVC resection has been done. The other resectable structures include the lung as well as the pericardium, and these can be resected easily, but in some cases, pneumonectomy has also been required. And when you resect the pericardium, it is always, if it is a major resection of the pericardium, which is not being closed primarily, then it's always prudent to reconstruct it. Anesthesia is a major component of the surgical planning as well as the surgery that we do. And we have to plan these cases in coordination with our anesthesia colleagues, because there are a lot of problems associated with a large mass which sits on the major vessels, the airway and the heart. So there can be a lot of airway and hemodynamic compromise. We may need lung isolation utilizing double lumen tubes. We need to assess the airway with a bronchoscopy before we start off. And we have to maintain the saturation with low FiO2 levels, especially if the patient has received bleomycin. Also, a large amount of fluid cannot be pushed in, especially if you're considering a SVC resection. So there's something that has been described known as the massive mediastinal syndrome, which can lead to death on table even during induction. Forget about surgery. And this is because general anesthesia can cause reduction of the lung volume as well as the relaxation of the bronchial smooth muscles, the respiratory muscles, and a greater compression of the airway by the mass. So we may lose the airway, we may lose the patient on table. And in case of huge tumors, we have to always keep this syndrome in mind. So in such cases, you have to do an awake intubation with spontaneous ventilation and avoiding muscle relaxation. So you need an experienced thoracic anesthetist. You should always have a rigid bronchoscope on table to salvage any mishaps. The surgeon has to be there at the time of induction. Sometimes you may have to intubate your patient in a lateral position, in a semi-lateral position, in a semi-prone position, whichever position which decreases the airway pressure. Inhalational anesthesia itself can cause, sudden collapse of the patient, and it has to be used judiciously. Short-acting IV anesthesia, IV muscle relaxant are what are preferred. And we must always prep and plan for veno-venous or cardiopulmonary bypass. And these should always be used electively rather than in an emergency setting. Wide bore catheters are always necessary, especially in the lower limb, because if both the... Yeah, 1 minute more. I have just 2 slides more.
Sure.
Yeah, so lower limb vascular access is really important. And when surgery is not possible, debulking usually has no survival benefit. We should avoid R2 resection. Airway or SVC stenting can be done when you have inoperable mass. And if there are effusions, these can also be drained. So this is a chart which shows a multidisciplinary approach to the surgical management and planning. And we must remember that aggressive surgical approach is advocated because there is a high incidence of residual viable tumor in non-seminomatous germ cell tumors. Every patient should be discussed in the MDT. We must anticipate and plan the complex resections instead of backing out because we do not have the requisite logistics. It is a team effort and we require a lot of multicentric prospective research. So thank you. Sorry, I overstepped my time. I'd be happy to take any questions.
Thank you, ma'am. Thank you for your wonderful presentation. There is a question in chat box, ma'am. How well does MRI predict pericardial involvement, especially in small tumors? And how often we see a scenario where pericardial not involved on imaging, but found to be involved intraoperatively?
Okay, thank you for that question. So the thing is that on CT, it's very, very difficult to predict pericardial involvement, and that's why we do a MRI. In small tumors also, MRI is quite specific. If there is transpericardial infiltration, that it is the tumor has gone through both the layers of the pericardium and is touching the myocardium, you'll definitely be able to see it on MRI, even in small tumors. Only the superior layer of the pericardium is infiltrated, but the layer which abuts the myocardium is free, then that is not a concern. And the next part of the question is where the pericardium is not involved on MRI, but found to be involved intraoperatively. So this would be very rare. MRI is quite good for predicting the pericardial involvement, but CT not so much. I hope that answers your question.
Yes, thank you, ma'am. And for the next talk, I would like to invite Dr. Akhil Kapoor, sir, who is Assistant Professor of Medical Oncology at HBCH and MPMMCC Varanasi. He would deliver his talk on follow-up salvage therapy in recurrent setting of mediastinal NSGCT and role of transplant and newer therapies. Over to you, sir.
Thank you. So I have been given task of covering 3 talk parts in 10 minutes. I will try to do justice, but I will be requiring to be very brief. So first, let's go ahead with the follow-up protocol. So after discussion of the entire treatment management, we'll discuss about the follow-up. So what is important to be understood is the basic concepts behind the follow-up, which is should be considered before deciding the follow-up protocol. At TMH, we have very well-defined protocols which patient should undergo what protocol for follow-up. This has been exclusively designed by Professor Amit Joshi sir and with help of the various guidelines. So intensity of follow-up is practically guided by the probability of the relapse over time. That is the most important point that should be considered. And we should understand that patients with seminoma, the median time to relapse is actually 14 months. But 1/3 of the relapses occur even after 3 years of completion of the treatment. So it is somewhat like ER positive, hormone receptor positive breast cancer. We can draw the analogy and can understand that patients with seminoma, they can relapse early and they can continue to relapse for a long time. NSGCT is somewhat like triple negative breast cancer. I am drawing the analogy because most of us are very familiar with the breast cancer, but have less familiarity with the testicular tumors because of the number of cases we see in our OPD. For men with NSGCT, 95% of relapses occur within first 2 years following orchiectomy. So it is again, I will say, it is like triple negative. Relapses are early, and if they don't occur, the prognosis is somewhat better, and the patients will not likely to relapse. So this is the first and most important point, the follow-up. And as I told, since the relapse chances are maximum in the first 2 years, first 1 to 2 years, the follow-up needs to be most intensive. And later on, we can reduce. So most of the guidelines tell that first 2 years, do 3 monthly tests and visits. And after that, you can reduce it to 6 monthly. 6 monthly for next 3 years. And after 5 years, you can reduce it to annual. Why annual visits are required even after 5 years? Because as I told, the relapses can be late and there is no clear-cut rule that the tumor will follow the protocol. Because tumor doesn't follow the protocol, we always try to find the analogy. I want to decide the best possible framework, but that might not always happen. That is, after 5 years, annual follow-up is still required. So this is what I told. Let's see the importance of tumor markers on follow-up. For men who have the completed definitive treatment, the tumor markers, FP, beta, HCG, LDH, usually these are measured at the same frequency as history and physical examination. That is, as I told, the frequency just now. The point that should be noted is that FP is the most sensitive to detect relapse disease, while LDH is the least sensitive and least specific. So most of the time we see LDH is 480, 500, 600, but still we are not very concerned because LDH can be raised in various other inflammatory situations. That is why we just note it, but we don't act on it most of the time. AFP guidelines say if AFP has risen by more than 25% of the highest acceptable levels, that means it is a sign of relapse. You need to investigate with a scan. So this is what I need to be concerned. So these are the NCCN guidelines, which are the usual recommended care. I will not go into detail of each one. However, I would like to say the patients who are been on surveillance after orchiectomy for seminoma, usually we try to give 1 cycle of or 1 to 2 cycles of single agent carboplatin. That is the most preferred by us. But still, some patients who are low risk, the risk of recurrence seems to be less than 15%. If the patient is willing for follow-up, we try to keep them on follow-up, and then we need to follow this protocol. The scans are usually done 6 monthly, usually 4 to 6 monthly, but most of the time we do 6 monthly till 2 years, and after 3 years we can do it 6 to 12 monthly, depending on the requirement. X-rays are usually not indicated, but usually contrast scan is recommended. That is the importance. Let's go ahead. So again, when the patients have received the treatment like radiotherapy or chemotherapy, apart from the normal routine scans and the follow-up, we need to understand that these patients are at high risk of developing metabolic syndrome and cardiovascular comorbidities. So these needs to be identified earlier. We have learned again multiple times from Amit Joshi sir and Kumar Prabhas sir that we need to follow these patients meticulously for lipid profile, for 2D echo, for the audiometry, for the even patients who are willing for family for further family semen analysis. So all these should be considered very well. Blood pressure, HGT measurement, these are small points which we as a clinician, busy clinicians tend to miss, but these should not be actually missed and are very important, and these should be always considered. So let's move ahead from the SMS follow-up. We come on to the salvage treatment options. So salvage options are divided into salvage chemotherapy and high dose chemotherapy followed by autologous stem cell transplant. I will be very short in this. There are 3 main regimens who are the standard dose salvage protocols. This is TIP, VEIP, and VIP protocols. So in TIP protocol, paclitaxel 250 milligram per meter square is given 24 hours infusion, but however, most of the times we tend to reduce it and give it over 3 hours. But there have been studies where it is found to be inferior to the 24 hours infusion. That is why wherever feasible, we try to prefer complete 24-hour infusions of paclitaxel with full dose in fit patients, because we are aiming at a disease which can be cured even in the recurrent settings. So complete response rates are as high as 70% and durable remission rates are as high as 63%. So still, after first time recurrence, durable remission rate is close to 65%. This should be kept in mind before, at the time of counseling, at the time of arranging finances. And VIP and VVIP are another protocols. So these are the protocols. The cure rates, as I told again, with the conventional treatment is close to 50%. But as I told, the CR rates are also very significant. And this is the study which I was quoting, 250 milligram per meter 24 hours versus not full dose and reduced dose over 3 hours only. That is completely different. So let's go to some high dose chemotherapy option. That is the Carvopec protocol, carboplatin, etoposide, and cyclophosphamide, along with hematopoietic stem cell transplant. So hematopoietic stem cell are actually given as a part of salvaging the bone marrow, because we are wiping out the bone marrow with the strong chemotherapy. So it is used as a salvage transplant. So we see that there have been significant results, multiple data sets which have suggested that there is benefit of autologous stem cell rescue in patients who have chemotherapy sensitive. Understand the process of meaning of the transplant. In this case, the disease will be refractory to high dose chemotherapy if it is at all not sensitive to chemotherapy. So you need to first check whether it is chemotherapy sensitive. If it is responding well to chemotherapy, then to wipe out the stem cells of disease, we can consider high dose chemotherapy followed by autologous stem cell transplant. So auto BMT versus tandem transplant versus TIP cycle, there have been multiple studies, and Tiger trial, this is the most awaited study which will tell us about the results. Results are deeply and highly eagerly awaited. I will not go into detail of the same, but here what is being done, TIP protocol is being given in the cycle 1 to 2, and later on from cycle 3 to 5, carbo, etopo, and cyclophosphamide is being given along with stem cell infusion on day 5. So this is the Tiger phase 3 study. There is no consensus opinion regarding the optimal initial salvage treatment, but we use these protocols. Also, in patients who are cisplatin refractory, understand what is cisplatin refractory. It is not like ovarian cancer where 6 months or is taken as a cutoff. Here, the patients who are progressed while on treatment or within 1 month of the treatment of chemotherapy with cisplatin are considered as cisplatin refractory. Others are not cisplatin refractory. And if these patients are cisplatin refractory, we can use the protocols like gemcitabine, oxaliplatin, gemcitabine, paclitaxel, whichever has not been used previously. And there is a prognostic scoring for the same: PFI platinum-free interval, AFP at the salvage time, SCG as the salvage time. The scoring is done, and this will help us to decide the overall survival outcomes in these patients. So this is the TMH experience. We have on data of 66 patients who have received DEP, and 110 patients have received. We have received 37 patients have received TIP protocol, and rest have received VBIP, VIP protocols. So stem cell transplant can be in a very small number of patients in our settings, being resource constrained settings, but we need to understand salvage chemotherapy should be given with full doses. So new drugs, there are some developments in terms of MSI high tumors, but it should be noted MSI tumors are only less than 1%, and pembrolizumab is approved for the same. So we need to find some better ways of treating these patients, especially in patients who are cisplatin refractory.
For the panel discussion moderation, I would like to invite Dr. Amit Joshi, sir, who is Professor of Medical Oncology at Tata Memorial Hospital, Mumbai. And I would also like to invite our panelists. First is Dr. Shubham Garg, sir, who is Senior Consultant of Surgical Oncology at Fortis International Oncology Center, Noida. Dr. Siddharth Turkar, sir, who is Consultant Medical Oncologist at NHMMI Hospital, Raipur. Dr. Sameer Srirangwar, sir, who is Consultant Medical Oncologist at National Cancer Institute, Nagpur, and Dr. Vipul Doshi, sir, Consultant Medical Oncologist from Solapur. Over to Dr. Amit Joshi, sir.
Thanks, Amit and Nandini for this meeting. And I think the most important thing that you have chosen this uncommon topic, which is not very covered in regular conferences, but it's a important malignancy, curable malignancy. So we should discuss the nuances associated with this treatment. So I think let's start this. So this is the mediastinum that we are going to discuss the germ cell tumor. So we'll start with the typical case, 24-year-old male resident of Mumbai, no comorbidity, smokers for 4 years, right-sided chest pain since two months. No cough or breathlessness, no fever. So presented with history of chest and breathlessness for 2 months. So I will like to first invite Sameer, in a 24-year-old male who presents with this complaint. What are the differential diagnoses will come into your mind when you see this?
Am I audible, sir?
Yes. Well.
So, sir, 24 age and a complaint of right side chest pain. Okay, sir, he's a smoker, but just 4 years.
Yes.
So, sir, basically, that means he may be having some mediastinal mass. which needs to be investigated further. So here, if there is a mediastinal mass, the most probably it will be lymphoma or germ cell tumor.
Yeah, so I think at this age group, I will further discuss. So I think the most important message is that even if the chest X-ray is normal and the patient is complaining of persistent cough, we should not, and that message should be given to the general physician or general surgeon, because the patient primarily reaches to them. So if any young patient presenting with a unexplained cough and dyspnea, which is not explained by the usual diagnosis, we have to evaluate further. So I think, can I ask Dr. Shubham, what is your viewpoint about the compartmentalization of mediastinum into the anterior, middle, and posterior? Why it is important to compare this three anterior and the middle and posterior compartment of the mediastinum, and how clinically relevant for the day-to-day management, and why we need to know the tumor of each compartment in a different way. Is Dr. Shubham there?
No, sir.
Yeah.
Sir is not there.
Yes. So this used to be a favorite anatomy question, sir, in the anatomy viva that describe the compartments. But just taking the previous question forward, that you know, the next thing that a clinician would ask when they are suspecting a mass lesion or unexplained chest pain in a young patient would be to get a cross-sectional imaging done. And that cross-sectional imaging in this case happens to be a CCT chest. And this is where the anatomical location of the tumor actually takes you towards a differential diagnosis. So there are very well-defined compartments, and each compartment has their most common and the least common probable masses. Like the interior compartment, we put them as the most common being the thymomas, where if it's a posterior compartment tumor, you feel that it's going to most likely be a neurogenic tumor. Middle compartment is something which we all of us stay away from. Usually it's a pure a cardiothoracic surgeon's field, but anything which does not explain something comes into the gamut of a tumor board discussion. But compartments, knowing the boundaries of those compartments helps you in creating that list of differential diagnosis on which you proceed further with your blood test.
So I think you very well described this thing that patient definitely needs a CCT cross-sectional imaging. And regarding the compartment, this is the chart or slide showing the distribution of anterior, middle, and posterior. And as you told that anterior, mostly the thymoma, teratoma, seminoma, lymphoma, carcinoma, and intrathoracic goiter in some patient. Middle is the mostly is the pericardial cyst and bronchogenic cyst, while the posterior mostly is the neurogenic tumor and other rare entities. So Vipul, at this age group, among the three differential diagnoses of a thymoma, that is a germ cell tumor or lymphoma, which one will you prefer, or which one will you suspect in this patient? And if lymphoma, what are the common lymphoma which is seen at this age and at this site? Hello, Vipul, are you there?
Sir, the connection was not stable. Sir, can you repeat the question, sir?
So at this age of a 24-year in an anterior mediastinal mass, which differential diagnosis among the thymoma, lymphoma, and the germ cell tumor you will consider? And if lymphoma, what are the type of lymphoma which usually presents at this age?
At this age, I would consider lymphoma as the first diagnosis. At this anterior mediastinal site, usually T lymphoblastic lymphoma, which one is the most common one, and another one is primary mediastinal B cell lymphoma is the second common one. Rest of the lymphoma, there is a possibility, but the possibility is much less, like a Hodgkin's lymphoma or diffuse large B cell lymphoma. The other things we can consider is mediastinal germ cell tumors. Apart from that, there can be a rare possibility of teratoma, thymoma. So these are the less common ones, even thyroid-related tumors.
Yeah, so I think you have rightly described the incidence of different anterior mediastinal mass. It varies from the age. So what you told that this red one is the lymphoma. So at this 10 to 19 or somewhat parallel, the 20 to 29, these are the common. And as the age little bit increases, the incidence of the probability of a germ cell tumor gradually increases. So as age advances, so in a 20 to 30, more or less these numbers are more or less same, but definitely in a relatively younger age group, lymphoma is more commonly seen over the germ cell tumor. But at the age advances, the incidence are more or less equal. So I think at this, but as the age advances, if you see this green one in a little elderly, the anterior mediastinal, then thymoma comes into the picture, and this is the most common at this age group. So that helps us in making some decision. So Siddharth, how you will like to go ahead in this case? So a CT scan is being done, which I will show later, which has shown a mediastinal mass. So what additional investigation you will like to do apart from the CT scan in this case? Siddharth.
Sorry, my mic was closed. So because he's just 24 years of age, and at this age, the germ cell tumor is a possibility. So I am, apart from the routine CBC, RFT, LFT, I am going to test for the tumor markers, serum AFP, HCG, and serum LDH. If that is not raised, then I am going to go for a biopsy for this patient.
I think the other important point.
May I add a physical examination of the testis?
Yes, so I think that's an important point which Subham has brought. Some patient may have a primary in the testicular, and they may have a metastatic disease in the mediastinum. Although till the time patient may have some symptom related to that, but that should be kept in a and definitely the other lymph nodal examination. So other point which I just want to highlight, that the CBC with MDC also should be done, because as the people were saying that T lymphoblastic lymphoma, so sometimes rarely you can get the bone marrow involvement, and the peripheral blood will show the picture of the blast cell in that. So CBC with MDC and along with the tumor marker are the first line of investigation in this. So I would like to ask, how difficult is to take a biopsy in this case? Suppose the first CT guided biopsy one was done, which is inconclusive, and the tumor markers are normal. So how difficult to get or what are the approaches if the CT guided biopsy is negative? Then how to approach this anterior mediastinum?
So the CT guided biopsies actually depend on the location and the proximity to the vascular structures. Small tumors, it is difficult to get a biopsy because they tend to be a little mobile and difficult to aim, especially if they are right below the sternum, because the only approach which is available is a parasternal approach, which is difficult if it's a central tumor. But if it's a large tumor, then biopsy usually is not an issue, but you might hit a necrotic area if it's a very large biopsy. That is the only problem with these. Now, I actually saw the comment, the question, the first slide, which said that no biopsy is also an option. So if it's a very small tumor and the tumor markers are normal, actually I would want to go in and get that small tumor out.
Yes.
If it's 2 or 3 centimeters, because it's really difficult to get a biopsy of those things, and you will be wasting a lot of time getting those. But if it's a 6 centimeters, 6.5, 7 centimeter, then getting a biopsy is not a problem at all.
Yes. So I think if the CT biopsy is inconclusive, then we can consider for a more invasive biopsy. So other point in terms of the etiology of this is that the rate of the progression, mostly the malignant lesion, they grow very rapidly compared to the benign slow growing implant like a benign teratoma or a intrathoracic goiter. So sometimes the rate of the growth or the rate of progression of symptom can give you a hint, and definitely the B symptom, which will be more common in a lymphoma compared to the other region. So I think that is another important aspect from that. So I think
just want to share
Yes, sir.
one of my
Yes, Samir.
experience.
Yes, please go ahead.
Yes, treated a patient. She was presented with nephrotic syndrome, diagnosed to have glomerular nephritis, and then incidentally diagnosed to have thymoma. So she was a case of thymoma with paraneoplastic nephrotic syndrome. So this sometimes happens. This can be sometimes a rare presentation, where patient present with paraneoplastic syndrome, and then patient later on
when on further workup you find yes. So apart from the myasthenia, can present with other autoimmune disease in this scenario. So sometimes this removal of the primary or the sometimes removal of the thymus may help them to get a long-term remission rate. So you are right. So I think the other important
treated her with surgery. She had a response for around 6-8 months, but now again having issues with nephrotic syndrome. But her disease, thymoma, is under control. There is no residual disease or recurrent disease.
Yeah. So I think this is the same issue also. So going for a surgery, removing thymus is not always helpful in resolving the symptoms. So that needs to be discussed. I think our surgeon, they usually discuss that this may give you some benefit, but we are not very sure. So other important point of view, which we'll again discuss, the teratoma. So that diagnosis, at least if the symptoms are not increasing very rapidly or a slow progression of the disease with a normal tumor marker, because except surgery, nothing can work in the mature tumor. So that also comes into the picture. So this is the CT scan of this patient, and then on the further workup. So it's 11 by 11 into 14.5 centimeter mass. The AFP was 537. The USG, abdomen, and scrotum all were normal. They further evaluated at TMS. By the time the tumor marker has further increased, and patient, then we admitted the patient. The ECG was normal, 2D co-normal, PTA bilateral normal. The sperm banking patient was not keen. So I will like to discuss the treatment plan in this patient. So Samir, how do you like to go ahead? This patient with a very large mediastinal mass, do you like to go ahead with biopsy in this case or not, or do you want to continue with the tumor marker, and if what treatment?
So sir, that there was actually a huge mass in the mediastinum, and clearly AFP was elevated and it was rising, almost doubled in in between few weeks times. So I think so it is a clear-cut diagnosis of mediastinal GCT, NSGCT. So in such cases, I think better to give a chemotherapy first and then consider for surgery as per the response. And in this case,
so in this case, chemotherapy and how you like to start in this case?
So definitely the preference here will be 4-cycle BIP. We have just seen in previous presentations also. So we have a good data which
suggests that like to start upfront. Yes, would you like to start with the upfront VIP in this case, or you will like to a patient is already having a difficulty breathing, or you will like to start with the some pre-phase?
Yeah, that depends, sir. Definitely, if the patient is, I think, a very heavy burden of disease, there is a high risk of tumor lysis syndrome. The patient is PS is not good. So in that case, we can definitely give single agent carboplatin, and after the patient is stabilized, then we can give our first regimen, that is VIP, first cycle.
May I just interrupt and ask, did we get a PET CT scan for the patient, sir? Because abdominal lymph node evaluation was...
I think Vipul, will you answer this question? Do you need a PET CT in this case? Vipul or Siddharth? Or even Samir, do you need to?
USG scrotum is being done and it was normal, and if there is no other site on CT also, that is also adequate.
But there's no evaluation. There's no evaluation of the abdominal retroperitoneal nodes. The CT was of the chest.
Yes, abdomen CT at least should be done.
Yes, CT abdomen should be done.
Even I don't think so that PET CT will be of help in this patient. CT abdomen pelvis should be done in this case, then that is sufficient to start the PET. I have no decision making in this patient at this point of time. I think I agree. I think the Vipul also agree with that. The PET CT is not. In fact, in all NSGCT at the time of diagnosis, yes. So that I think that's an important message, that PET CT does not have any value. At least in NSGCT, the only value of PET CT is in the response assessment for a seminoma which is more than 3 centimeter. So a patient started with 3 days of cisplatin, what we call a mini EP, and then he had some symptomatic relief. We admitted the patient and given first cycle of VIP as expected, has a grade 3 febrile neutropenia and was planned for second cycle of VIP. But at the time of admission, he again complained of increased difficulty breathing in, chest increase and PS again treated. So how you like to proceed this case further in patient who have some symptomatic benefit and then again worsening of the symptom?
So tumor marker repeated.
Tumor markers repeated, which were normal, which are reducing trend. Samir, you can.
So he had symptomatic worsening, but tumor marker were reduced.
Decreased. Yes.
So I think better get a scan done again, sir, to see what is happening.
Yes. So I think you are absolutely right. We went ahead and done a CT scan, which shows that now the tumor is more necrotic and the overall size has increased, and there is a disease progression in terms of the overall lesion. If you see it's occupying almost almost whole of the chest cavity and symptomatic. So how will you approach this? I think you will come into the picture. So
yes,
how will you like to approach this case?
So although the tumor is responding to the therapy, but as we can see that there's still progression on the size, probably it's a necrotic part which is increasing. So in that case, it is better to go in and take the disease out. And the best way in this case would be to do a median sternotomy. It might require extension on the right side in a T-shaped fashion, but
so Shubham, what sort of morbidity and is there any chance of life-threatening complication in this case? So how we have to counsel the patient? In fact, when we have to send the patient to the surgeon, we have to tell them that this is this. So how complicated surgery is going to be this, and what are the chances of intra-op mortality or life-threatening complication post?
Usually these mediastinal GCTs have a well-defined plane. It is probably only because of the size of the mass that it appear to be infiltrating. But if you go slowly and steadily, you can get them off the vessels. However, with this type of disease, I would want to have the cardiothoracic team stand by. So in case there is any vascular injury, they can very well be a part of it. This is a curable disease, and I would want to go with a radical approach. If there is a part of SVC which needs to be resected, I think that would be on the card as well. But as I can see, probably it will not be required. But we counsel the family about major blood loss, ICU stay, need for a vascular repair. We tell them all about this.
Yes, so I think you are absolutely right. We took our the thoracic team opinion, and they decided that since the disease is progressing, options are very less. Patient underwent medial sternotomy with right partial clamp cell extension, and with pericardial excision plus mesh reconstruction, and the histology was sensitive of a residual viable NSGCT, and with majority of the component with teratoma, and the post-op marker was again started falling, and so the patient after this surgery, the patient came asked, and then what will be the next line of treatment will you offer? Now the tumor is R0 resection, tumor has been totally removed. Do you still like to go ahead with chemotherapy, or you can stop? I think Vipul or Samir can take this question. The tumor has been removed.
I'll take this, sir. Okay.
Sir, as AFP is still raised, we should complete the adjuvant chemotherapy.
I agree with Siddharth.
We all know that. Yes, and Samir, what's your opinion? Do you want to stop or continue?
No, we should complete all cycles of chemotherapy.
Yes, so that we discussed with the patient. Patient is not very keen, and now 2 cycles of chemotherapy taken, and now he doesn't want to go ahead. We have to just need to take complete the whole four cycles. So it's a poor risk disease. Even the tumor is being removed, even if the tumor marker have come down, since there is a residual viable tumor, I will like to complete the whole 4 cycle of evidence. So the important message that early intervention in form of surgical management is very important. If there is a progression, patient is on chemotherapy. The other aspect which I have seen within common is that even after end of the chemotherapy, his tumor marker is slightly on the higher side. Say the AFP is still 50, 60. I usually send them for a surgical opinion because in this scenario, the Salvage chemotherapy is not very effective. So even if a low level of raised tumor marker post 4 cycle, we should send for aggressive surgical. That is the important message in this. So I think we'd like to discuss something about other important. Have you anyone encountered the paraneoplastic syndromes, paraneoplastic NSGCT that described in the literature, but how commonly you've seen? Anyone? The literature says is around 5 to 7%, but and so the important message is that if any patient with a mediastinal NSGCT comes with a say lower platelet count or the total count is on the lower side, you should be suspicious that is there any association with any hematological malignancies, and most commonly which is described the plastic leukemia. And I have seen only 2 cases till now, but the literature is quoting like this. And similarly, the idiopathic thrombocytopenia. So what I meant to say that the paraneoplastic questions are the mediastinal NSGCT compared to the primary testicular we don't see that commonly. So any abnormality in the lineage, either hemoglobin or this it's a little bit you should not miss. One patient syndrome, it's rare, but definitely you have to be ready with that. So regarding the management of this, which chemotherapy regimen, Siddharth, why you don't want to, your choice will be 4BP or 4VIP?
Sir, as a first line, I would prefer VIP regimen.
So, Vipul and Samir, what will be your?
I would also prefer VIP as a first line regimen to prevent pulmonary toxicity.
Any particular reason for this?
Sir, it is difficult to, the patient is already a smoker and it is difficult to assess the pulmonary function test because of the mediastinal mass. So that's why giving bleomycin will be a bit risky, better to go ahead with VIP. And again, it is more more intense treatment, and disease, it is better to give that regimen. That's what I.
Samir?
So sorry, my network was not stable. Can you repeat the questions?
So which chemotherapy, BP or VIP, will you prefer, and any reason for that?
In mediastinal, sir, mediastinal GCT.
Yes, NSGCT.
Sir, basically in mediastinal GCT, majority of the patient requires surgical excision if it is NSGCT. So from that point of view, if you see the post-op mortality or morbidity, if there is a underlying bleomycin toxicity, it can be difficult for surgeon to handle. So in that way, it is better to use VIP rather than PEEP.
You are perfectly right. This was one of the morbidity and mortality associated with bleomycin primary mediastinal. If you see the surgical complication, come to this number. That patient received bleomycin and who were not received bleomycin. The acute respiratory distress or the syndrome or pneumonia, it's around 15%. The perioperative death is around 7%. And the prolonged ventilator use is around 18%. So that means those patients who receive bleomycin for their management for NSGCT, post-op complication is going to be a very difficult issue compared to the no bleomycin. So that is one reason. So I will just like a quick question with you. So how concerning is the bleomycin, use of bleomycin in that scenario? What are your concerns as a surgeon and with your anesthetic team?
The concerns post bleomycin are that there is a lot of changes which are not seen on CT scan. So actually you cannot predict that this patient will have post-op morbidity. So it is really a challenging thing to predict that this patient would not have any cardiac issue. But if a patient would to have significant oxygen dependence or a poor exercise tolerance, then it would be challenging for us, especially in case of mediastinal GCTs, to offer them a complete curative surgery.
Sir, again,
one
point here, mediastinal NSGCT are poor risk. So you don't have any option of here 3 BP. You have to give 4 BP. So
Yes.
the cumulative dose of bleomycin also significantly higher here.
Yes. So I think this is one of the paper by the Indianapolis University, and what they concluded that the bleomycin risk was associated with significant complications. So, but they concluded that even in their institution, they are using VIP as therapy of patient primary mediastinal since early 90s. So I think that is the reason they are. So that what I told you, another important aspect for the teratoma. So Subham, how to diagnose? So this mature teratoma this is the tumor where chemotherapy will not work, and sometimes medical oncologist is being called to give chemotherapy. Tumor markers are normal. So how we will
the age group of the patient, the radiological appearance, if it is having any differentiated features like having a well calcified teeth looking structure, then it is we know that it is most likely to be teratomatous lesion. Then having a normal tumor markers also pushes you towards looking at a more teratomatous growth. Biopsy may or may not be helpful, like I said, because it can throw surprises. You might get a squamous cell carcinoma, and then you are wondering where did you get squamous.
So I think the most so Subham, I think most important thing is the rate of progression of the symptoms and the CT scan findings. There is an area of fat, areas of calcification, bone formation. So and tumor markers are normal. USG testis is normal. You are reasonably sure that we are dealing with, and the chemotherapy is not going to help. So we have to put this to go for a surgery, and we should not venture into chemotherapy in this same scenario. So I think I will just so go to one or last 2 slides on mediastinal seminoma. So Siddharth, what's the difference between mediastinal seminoma with NSGCT in presence in the way of presentation and the management? I think Samir or people can take if is not there.
So, sir, in seminoma, you have to get a biopsy to confirm the diagnosis.
Yes. So I think that's a very important point. And mediastinal mass with the tumor, normal tumor marker, and the most important thing for a mediastinal tumor is the immunohistochemistry. You have to be a very good, because the things can range from anything from the thymoma to the lymphoma. So a good pathological team with the experience in dealing this type of tumor should be there, and good. So this is just slide showing about the so if you have to differentiate with this, these are the markers which we do D40, and this markers very much required, and the immunohistochemistry has to be used to differentiate with other mediastinal tumor. And is there any different way to manage this tumor?
Sir, again, residual masses need to be managed differently. So for NSGCT, like any residual mass need to be resected. For seminoma, so we may extrapolate the cutoff of 3 centimeter and then decide what to be done.
So I think you are right. Mostly the testicular seminoma is managed like a testicular seminoma. So mostly it will be a good risk. Rarely they present with a distant metastasis like a pleural deposit, or very rarely to the bone and liver. In this, so there is no poor risk in the mediastinal seminoma also. Prognosis is good compared to the primary and residual region. We approach like a seminoma that need to be assessed after 10 to 2 weeks, preferably with a PET CT in this. But there is no specific guidelines we testicular for the management. So I think I would like to thank you for all my panelists and the organizer for giving this different touch to this meeting. Thank you, Amit and Nandini.
Thank you, sir. Thank you so much. Good night.
Yeah.
Thank you, Amit Joshi sir and all the panelists. Thank you, Dr. Nandini and Dr. Rushabh for organizing and conducting such a wonderful session.
So, thank you all. I think we can close the session for today and meet again tomorrow. Thank you.
Thank you, ma'am. Thank you, sir.
Thank you, everyone.
Thanks,
Thank you,
Amit and
everyone.
Gurvinder and
Good
Ajay.
night. Good night, everyone. We'll meet tomorrow.
Good night, ma'am. Thank you.